Well, welcome everybody to Eat, Sleep, Console. My name is Ann Mock with the Community Engagement Institute at WSU. I am joined by Quinlan Roth, who is helping us behind the scenes here at WSU to make sure all of your technical issues go smoothly. If you have any technical questions, you're welcome to reach out to Quinlan in the chat. In order to access the chat, you hover your mouse over the bottom of your screen. It brings up the chat option. And then you have an option of whether you want to chat to everyone or if you just want to chat with Quinlan. You can choose him from the drop down that says Quinlan Roth, and Quinlan can answer any of your technical questions from there. If you have any content questions, you can reserve those for Betsy. And with that, I think I will turn it over to Betsy and welcome you all to the day.
Okay. So I do thank you guys for being really flexible with us, especially in this time, and joining us for the didactic portion of Eat, Sleeps, and Consoles. We will schedule the simulations as soon as we can get back into the simulation labs, and that will be sometime in late July is what we're targeting now. I think we want to schedule them so that we don't have to reschedule them, and we are looking at late July. So right now what I want to do is just kind of do an overview of the day, and then I want to go around the room and I want you guys to just give a brief introduction of yourselves and just kind of tie yourself with what center you work with. So what we're going to do this morning is we're going to do kind of some site reflections. We're going to go through the Eat, Sleeps, Consoles tool, but we're also going to look at just NAS pathophysiology. We're going to look at the Finnegan, the modified Finnegan in comparison to the Eat, Sleeps, Consoles tool. After we take a break, because we can't all sit at our computers for 4 hours straight, we're going to do some simulations, talk through simulations. We're going to show a video, just kind of preparing you guys what to expect when we do get into the simulation labs. And then we're going to talk through some case simulations. This will be a group participation. And then we'll talk about how to implement it when you guys take it back to your centers. And then we'll do a group project. So with that, I just want to go around the room, and I can't see the room, so
I can see the room.
Okay, so Dr. Jackson can see the room, so she's going to have you guys introduce yourself one at a time. Yes.
No, you don't. Okay, sorry for that delay. That's your trouble muting yourself. Okay, so I'm Dr. Jackson. We're going to be trying to share different parts of this presentation. When we did it in real life, it went super smooth. When we do it virtually, it takes a second for her to mute and me to unmute. We're in the same room, but we're socially distanced from each other on different computers and have different views. So I have the gallery here, and so I'm just going to call out names as I see them. I have pictures of some people and not others. So I'm just gonna, if it's okay, go in order of the gallery I have, which is probably arbitrary. But after Betsy, I have Shelby Downing. I can only see your forehead though. There, now we can see you. I'm gonna mute and you go ahead and unmute and tell us where you're from and what your hopes for today are.
I'm Shelby. I'm a labor and delivery nurse in Wichita, Kansas at Wesley Medical Center, and I work night shift. So I would be the super user for night shift of this process.
Shelby, I'm sorry, we didn't have our mute on. Can you repeat that?
Can you hear me now? Woo! I'm Shelby from Labor and Delivery in Wesley Medical Center in Wichita, Kansas. Anybody hear me?
Just shout.
Okay.
Okay, can y'all hear me now? Okay, good. I'm just shouting through Betsy's. So thank you, Shelby. And next I have Michelle Too Good.
Michelle's from Hayes.
She's not talking.
Okay.
Okay, can you guys still hear me? Sierra Jones?
Can you hear me?
Yes, we can. Go ahead, Sierra.
I'm Sierra Jones. I'm a labor and delivery nurse at Wesley Medical Center.
Okay, and I have Lori next.
I'm Lori Gwynn. I am a newborn physician at Wesley Medical Center.
Thank you. I have Danielle Lyman.
Hi, I'm also from Wesley. I'm one of our clinical educators here.
Thank you. Is it Jimmy?
I don't know how to change my name. I'm Jessica from Wesley Medical Center too.
Thank you. I think there's an extra J and no A. Thank you. And I just saw a chat from Michelle, but it disappeared. She may be having trouble.
I can read it for you if you'd like.
I see it. She says, I can hear you, just no audio on this computer. I'm a clinical supervisor and OB, L&D, NICU lactation at Hayes. Everybody hear that okay? Okay. Alicia Sanchez.
Hi, I'm Alicia Sanchez. I'm one of the newborn hospitalists at Wesley.
Thank you. Amy Henry.
I am the nursing manager at Ascension Via Christi Hospital in Manhattan.
Oh, thank you. Great. And Kayla Schroeder and somebody else.
I'm Kayla Schroeder. I work at Geary Community Hospital. I'm a labor and delivery nurse and lactation consultant.
I'm Kendra Case, and I also work here with Kayla as well.
Thank you. Heather, just plain Heather.
Heather Aiklin.
Aiklin.
Hi, I'm a postpartum CNC at Wesley Medical Center.
Okay, now I've got a lot of names with no pictures. Heather, we lost your picture, I think. Next I have Lindsay.
Lindsay doesn't have video or a microphone. This is Amy. She's also at Ascension Via Christi Hospital. I think she typed it into chat for you.
Great, thank you. Chapel just came up.
Becky Chappell's
Becky Chapel.
Hi, this is Becky Chappell, Western Tennessee.
Okay. I wonder if the rest of the people on the do we have a feedback? No. Okay. I've got Carol. Aimee texted it. Oh, Lindsay said I'm a nurse. We agree to see that. Aimee, to everyone, I say Zoom cannot recognize my camera. It says to make sure my power is not connected. Quinlan, can you help her with that?
I'm sending her a message right now. I'm trying to figure it out.
Denise and Cheryl.
Hey, this is Emily. Can you hear me?
Yeah. Yeah.
Okay. So I don't have a camera, but I can see all of you.
Okay.
I'm a nurse, technically challenged nurse. I work at Wesley Medical Center and I do labor and delivery.
Okay. Thank you. I have Hayes Med. Some people from Hayes that are there.
Hi, this is Jessica. I'm the educator for OB, labor and delivery, NICU.
and I'm lactation consultant also. And Michelle may be joining me over in this conference room at some point, but she's in her office now. So, and we may have another, our director, Christy Schlafly, at some point as well.
Thank you. I have Christy. Do you want to say that name? Sorry, Christy, I'm going to butcher your name if you can hear me. Schlafly. Maybe you can't hear me. Erica Geen.
Erica's in the office with me on the other side, but doesn't have an audio option.
Okay.
She's the NICU educator here at Wesley.
Thank you. We just got Carol. Carol, I am a manager of postpartum at Wesley. Michelle, CNC is with me. Got it. My camera and microphone don't work. Yeah, I know how that feels. My desktop at home is the same. If there's anybody I didn't call, because these kind of went out of order as I was going through them, please either unmute and tell us about yourself or send a chat in so we know you're there. Okay, so I guess that's everybody. Okay, this is going to be a fun ride. Everybody stick with us. Hook your seatbelts.
All right. So what I did was I sent you guys packets, and we are going to go through the packets. And I know Danielle at Wesley nicely took the packets and copied them and gave them to her site. In your packets, I have just kind of stapled together on the right-hand side, kind of the order of how we're going to go through today. And then the left-hand side, you guys, those are for your sim labs. So keep those for when we do meet in sim labs. As far as the facilitators, we introduced ourselves. Dr. Jackson's in the room. I'm in the room. And I think Paula Delmore was going to join us. She may pop up yet today. She is also an instructor for us for Eat, Sleeps, and Consoles. She's at Wesley Medical Center. And she will also be helping us with sim labs when we have them in Wichita. Learning objectives for today, participants will be prepared to use recent evidence that supports a change in assessment skills and care management of exposed newborns, and that teams will develop at least one action plan for improved management of opioid-exposed newborns in their settings. So we hope that from this didactic portion, you guys will be able to take back at least one action plan that you can take to your center. It may not be implementing Eat, Sleeps, and Consoles, but it may be improving upon what tool you're using today. So that's our goal. So I sent out some videos and some pre-work for you guys to look at. And so what I want you to do, and I've identified on the next slide who's going to be your spokesperson, just kind of what your goal for today is for your center based upon your site ability. So if you're a big center and you have the ability to do rooming in and parent consults prenatally, you're able to just implement Eat, Sleeps, and Consoles. You think it might be that you're going to do the whole thing as you looked through these videos, and it might be that you just want to take one or two elements back as we get through this. But just looking at the webinars beforehand, just thinking of what your site looks like and what you might be able to do. And then we're going to circle back and look at this later. I want you guys to just kind of first identify for me what one thing your center wants to get out of the training today, and maybe one weakness for me today that might impede you guys to put Eat, Sleeps, and Consoles into place. So I probably should give you guys the whole slide deck in front of you. So we're going to go from center to center, and I'm just going to have you guys speak on those two things. So Kayla, if you'll go for talk for Gary about one thing you want to gain, and then one thing you can think that would impede your ability to do it.
You're muted, Kayla.
We are wanting to switch from the Finnegan to the Eat, Sleep, and Console. We're working on changing our policy. Probably our one barrier is going to be getting both of our pediatricians on board. I think I have one of them. It's just getting them both on board and agreeing to it.
Okay. And so, and we can talk more about that towards the end too, but we are recording this so you can, and you can share a lot of this with them through the recording too. So, okay, Michelle? Oh, is she muted?
Michelle, yeah, she's the one that didn't have a speaker.
Okay, so.
Wait, somebody just texted something in. Hold on, I'll look at the chat.
So Becky, why don't you skip ahead of Michelle?
Hi, I just want to absorb all this information. I don't know anything one particular. We're a small hospital. So it's hard to get things rolling here from that aspect because of we're a critical access hospital. So I'm really not sure how to answer the question yet.
Sure. So, and Heather?
One Heather. Oh wait, Heather's not good.
Oh, she doesn't.
Yeah.
Okay.
Maybe, Heather, if you're there, maybe you can chat in something.
Okay.
Oh, here it is. Oh, this was an old one. We're logged in as Heather. We want to educate our staff on identifying NAS signs and symptoms and getting our OBs on board prenatally.
Okay.
And I don't know if you want to say something else or not.
Okay.
That's a good start. Thank you.
And Danielle?
We've decided as a facility that we want to switch to Eat, Sleep, Console. So just figuring out how that looks. And I know they said they have a small hospital. We have a large facility. We have good buy-in from our pediatricians, but just probably bias since I'm the educator, figuring out how to do return demonstrations for all 200 of our nurses is a little daunting. So that's probably what I want to figure out today, but we have a good team to help get that done.
Sure. And Amy?
We're a small facility also, and we don't have a lot of NAS babies, so just being able to switch from the Finnegan, which we aren't really comfortable with anyways, to using Eat, Sleeps, and Consoles, we think it's just where we want to be.
Okay, thank you. Okay, so we are going to go ahead and start into the main part of the PowerPoint. And then as we go through this, like I said, in your packet, you will have tools that we will go over as we go along. The first part you won't have tools for. So.
Yeah, I'm gonna go. You wanna? Just mute yourself.
Sorry. Oh no. I'm going to switch over so Dr. Jackson can
Just
talk.
mute yourself.
Okay.
But you can leave your sound down. Okay. No. Okay. No. No. Sorry. don't think you're still not muted. Do you want me to come over there and wipe it down?
Would it help to keep just audio coming from one laptop and keep, and that way you only have to mute?
Can you hear me? No. Okay. We need to unmute Betsy. Quinn, can you help?
There you go.
Can you hear me now?
Yep.
Can you hear me now? Just keep yours over there. I'll just talk about. Can you hear me now?
Yes, we can hear you.
Can you hear me? Nobody's nodding. Oh, there. Amy's nodding. Danielle's nodding. Okay, people are nodding. You can hear me okay, right? Okay, I'm just shouting to our computer, and that's what we'll do. I've got the slides here. You can just move them.
No, I'm just putting my computer.
Oh, so closer. Oh, yeah. Okay. Here we go. So sorry about that. It worked a few minutes ago. Okay, so we're going to talk about the start with the pathophysiology of opioid withdrawal. And I think a lot of you know this, and it's a lot of review, but I'm going to talk about it kind of the way I talk to families. So I think we know, like in our mind, what the problem is, but it's hard to relay that to families. So what I say to families when I start is basically, you know, if you're taking medication, whether it's, you know, whatever it is, prescription because you needed it, or, you know, something else that wasn't prescription, whatever medication you're taking, your body gets used to that. And your cells upregulate to expect it. That's the physiology of what happens. But basically what you feel is you get used to it, and the same amount doesn't have the same effect. And that's because your system that detects the medications or the drugs changes so that you expect it, your body expects it. And then what happens when you suddenly stop, so for a lot of women, they know they've tried to come off before, or they've missed a dose or whatever. When you suddenly stop, you really feel it in your body because your body expects to have that medication and it doesn't. And when that's what happens with babies when they're born, they've had this medication available to them for 2 or 3 or sometimes 9 months. And suddenly it's not there anymore. And their body's expecting to see the medication or the drug, and it's not there. And so a lot of times when I just say that, you know, women kind of get really upset and cry because they know how bad withdrawal feels, and they realize that's what their baby's going to feel. And if we can meet with women way ahead of time and have them know that and have that discussion, it's a lot easier. And a lot of times, and I think everybody probably knows, we don't, if mom is on a prescription med, or she's in a program, or she's taking narcotics for some reason, our goal isn't to get her off during pregnancy, because that's fought with a lot of other dangers, which I have a whole presentation on. But basically what the literature tells us is it's dangerous. It can be dangerous for the baby, even if it's done in a controlled manner with a program. The risk of rebound of before the baby's born is so high that it really counteracts any of the women who actually come off and stay off. And the only women who are able to come off and stay off are in-house intensive programs, and those aren't a lot. So that's a whole nother discussion we can have someday. I think we actually did a webinar on it, so you could probably find it and pull it up if you wanted to. So basically, that's what this slide says. The longer acting have a longer acting effect, the shorter acting, obviously a shorter acting effect. Can you go to the next slide? I think this pretty much says the same thing. The opioid receptors increase in the brain and attempt to receive more opioids. This leads to the withdrawal symptoms. So I just said that kind of in plain words. Yeah, we'll go to the next slide. So lack of the opioids leads to a chronically stimulated state, leads to upregulation of the cyclic adenosine cycle, which I'm going to show you a nice little picture of in a second. Increases the production and release of various neurotransmitters through complex mechanisms. Withdrawal is a result of increased production of noradrenaline, acetylcholine, corticotropins, and other substances, as well as a decrease in serotonin and dopamine. So this next little slide, or big slide, is a little complex, but it tells you basically, I can't see the top. Hold on, I just gotta move you guys. There we go. I got a bar of my gallery, it's over the slide. So the middle talks about a lack of opioids in the chronically stimulated receptors. You get superactivation of the adenyl cyclase system, increased cyclic adenosine monophosphate, increased protein kinase, increased neurotransmitters. And those are a lot of kind of things you don't have to know about, a little molecular, but what you need to know is where it goes in the arrows. So when you have an increase in corticotropin release, which is at the top of the, can you point to it? Because I see your screen at the very top. Yeah, there you have increased stress and hyperphagia. And then when you have dopamine decrease to the right here, you have the hyperirritability and the excitation. So this is just telling you neurotransmitter why you see the symptoms you see. So, you know, a lot of times you go through all these symptoms and say, well, they have diarrhea and they have sneezing. Well, why? Well, if you come over here to the one to the below to the right, the acetylcholine increase, that's what causes your diarrhea, vomiting, yawning, sneezing. And that's why as we go through and talk about Eat, Sleep, Console compared to Finnegan, none of these things in this box really count for Eat, Sleep, Console unless your diarrhea is so bad that you're losing weight. But they are signs of withdrawal. So that as we go through, we're going to talk about the Eat, Sleep, Console system, but also keeping in mind the signs of withdrawal. So if a baby's sneezing and sweating and yawning, he may not need to be treated if he can eat and be consoled, but those are landmarks that withdrawal is happening, and it alerts you to withdrawal is happening, which is important. Can you guys nod if you understand what I'm saying? Because this is an important point, and I can't see you. Does that make sense, or do I need to say that more about that? Does anybody have a question? You can chat something in if you have a question about that. We're going to hit this several times, emphasizing that Eat, Sleep, Console is an important functional mechanism and helpful in making decisions about treatment. Thank you, Amy, for the thumbs up. But knowing the symptoms, the Finnegan symptoms, or just the symptoms that are captured in Finnegan is super important to knowing your baby's withdrawing and knowing that in your mind so you can increase non-farm care and those kinds of things. So good, thank you. So then down we have the other receptor activity, the hyperalgesia, and I can't see what's underneath that. But you guys maybe can. And then to the right, the noradrenaline increase, that's when you get temperature instability, hypertension, tremors, tachycardia. Again, if they're eating and sleeping, that might not count against them, but if you see that happening, you know there's a problem. And then serotonin decrease at the upper corner there is when they can't sleep well. So those are all the mechanisms of some of the symptoms that we see, and it's important not to forget those as we look at a more functional system like Eat, Sleep, Console. Okay, next slide, please. So I guess this is probably going to say what I just said. It's important to recognize all the symptoms, even if you're not going to make action. Now, do you guys have all these slides, right? I see people taking notes, but you should have access to these slides.
I didn't send it.
Oh, Bessie said she didn't send the slides.
I will send it to them.
She will send you the slides. Sorry. Is there any way, Anne, that we can upload them or get them out while we're talking? I don't know where Anna is.
Yeah, Dr. Jackson, I could send them out, but I don't have a complete list of email addresses for all of our participants.
Okay, well, I guess we'll get them out after. I'm sorry you didn't have them before, but you will get the slides. And it's being recorded, so you could, get the slides and go back if you want, or you can take notes. As the symptoms start to increase, like I said, they're kind of markers for heading in the wrong direction. This is just what I said, but with these symptoms that we're looking at, can they eat, can they be consoled? But the other problems can lead to not being able to eat or be consoled, and they can escalate. And let's go to the next slide because I pretty much hit this hard. So I really love this slide. We took this from our training with Bonnie Whalen when we got trained in Eat, Sleep, Console. I love this slide, and it's something I think as people transition to Eat, Sleep, Console, they should think about printing to be like a little pocket thing for nurses to hold on to. Because if you truly switch to Eat, Sleep, Console, you're not going to have access to all of the symptoms of NAS, which you have on your Finnegan checklist. And yes, it's kind of excessive. You're not going to treat somebody just for sneezing, and you don't necessarily want to give them a higher score just because they're sneezing, but you want to know that they're sneezing because it's a sign that they could be having a little withdrawal. So this is basically the list that's on the Finnegan. Does it look familiar to everybody? So it's the list that's on the Finnegan, but you're not trying to score it. You're just being aware that these are things that could be related, especially as we get a generation or two into Eat, Sleep, Console. So most of the nurses and people now are familiar with Finnegan. And so while they're transitioning to Eat, Sleep, Console, they're going to remember some of these things are part of NAS. But as we get into it, 10 years or 15 years from now, we have new nurses who've never seen Finnegan. We need them to know these are still some signs of withdrawal. And then I'm going to show you some fun things I think are fun. So for example, this, you see the boxes, right? The undisturbed tremor, yawning, mottling, stuffiness, sneezing. Okay, so if you had all that, that would give you a score of 9, I think, which would be a Finnegan score of 9, which would mean that you are heading toward treatment. But if you had all those things, we wouldn't really necessarily want to treat you. We just want to know you're starting to go into withdrawal. And so that's where Eat, Sleep, Console comes in. It's like the common sense. And again, another option, I think some of you said you weren't sure what you wanted to do. Another option is to use what we call prioritized scoring, where you give a heavier weight to the things that really matter and a lower weight to things that don't matter as much. So you have all of these things in front of you, but you weigh according to what matters more for the health of the baby. And that's a way to kind of combine Eat, Sleep, Console and Finnegan. And some centers have done that when they're not fully ready to transition. And it might also be a nice segue into transition. Okay, let's go to the next slide. So the next slide is 3 signs that baby has hyperactivity, undisturbed tremor, and increased tone, but he's not, excessively sleeping. He's not throwing up. And this is what score is this?
8.
That's an 8. So again, these are signs, but you don't need to start thinking about treating with these signs. But with your traditional Finnegan, that's an 8, which would alert you that you might need to treat. And then next slide. Now this is a problem. This baby is not sleeping, he's not eating, and he's not consoling. So this is the definition of Eat, Sleep, Console. He's not doing any of them. This score gives you.
This is a 9.
So this is a 9. So this 9 is, and the 9 I gave you 2 slides ago, obviously are not to be compared. Not if you understand what I'm saying and get it, because this is the crux of what the whole story is. Yes, I'm looking at you people. Not if you. Does anybody have a question? Because this is kind of one of the most important concepts to get as we go through this. Does anybody have any question? Oh, Heather says she's nodding. Heather, thank you so much for your chats. Anybody else, feel free to. Emily's nodding too. Good. Okay. Anybody not understand this? This is, like I said, that it's really hard to do this online, but this is the crux of the story. A 9 in this scenario deserves moving toward treatment. A 9 2 slides back, can you go 2 slides back for me?
Uh-huh.
This 9 does not deserve even consideration of treatment. You know there's a problem, you want to step up non-farm care maybe, but you're not going to think about treating this. So, and that's what the Eat Sleep Consult people will tell you. And this 8, obviously, you're not going to treat. Go forward. Yeah. And this is where the people who developed it say, it's common sense. Like they took a step back and said, why are we looking at these arbitrary numbers that aren't necessarily reflecting a baby doing what a baby needs to do? We need to know if the baby can do what he needs to do, which is eat, sleep, and be consoled. And that's their argument. This is common sense. And it is. But if you exclude the rest, if you just take these in exclusion to the rest, you can also see, I hope, that that would be a disservice to understanding what's going on. Yes. Yes. No. Yes. I can see you guys. You just have to nod. Okay, thank you. I can see about half of you.
There's also the option, if anybody would like to, I've seen a couple people use it, but if you click on, if you hover at the bottom of the screen, of the video screen, you should see like something called reactions, and you can do a little thumbs up that way. Yep.
Oh. Oh no.
There you go.
Okay. Yay, thank you. Quinlan, thanks for staying. He's like the all-knowing, all-hearing.
No problem.
Okay, thanks for those thumbs up, folks. Okay, let's go to the next slide. Okay, so I'm not sure how well you can see this, but I'm sure that you've seen it before. This is a Finnegan scoring sheet and gives you numbers for all those symptoms we've been talking about. Has anybody not seen this before? Give me a thumbs down if you've never seen this. Okay, I don't have any thumbs down, so I'm assuming everybody's seen this before. Okay. So the traditional Finnegan talks about when to treat, and like I said, that can be modified. So traditionally, we talk about
This is Watchman's approach.
who's?
Watchman's approach and how they modified.
Oh, this is Watchman's modification. Okay, but before I do that, I want to talk about what traditionally. So traditionally, what people have done with Finnegan is if you have 3 scores above 8 or 2 scores above 12, you get treated without any kind of weight on why your scores are high. And for those of us who have been working on this for a few years, we've started to ask the question, why is the score high? So, okay, you've had 3 9s, but what's the reason? And kind of informally trying to assess it that way. But this is Watchman's first, the references at the bottom corner there, kind of first attempt. And over these, there's several papers where they're kind of moving toward what we package now as Eat, Sleep, Console. But so for them, 2 scores greater than or equal to 8, 1 score above 12, they moved to a team huddle to assess what the symptoms were. So that was the parent, nurse, and physician. They assessed infant for the big ones. Are they eating? Are they throwing up? Are they having diarrhea? Are they consolable? Are they sleeping? And then assess, are we giving enough non-farm care? Now, non-farm care means comfort care. So skin-to-skin holding, lights down low, binky if they need it, quiet, rocking, all the things I think you guys know about, we've been talking about for the last couple of years. And then if we can't do enough with non-farm care, medication would be used after maximizing farm care. And this is kind of the crux of what Eat, Sleep, Console became. So it's using the Finnegan scoring, but it's prioritizing the symptoms, talking about the ones that really matter, and upping the farm care, which are the important things about Eat, Sleep, Console. The thing that Eat, Sleep, Console does that's different than this is it forces those non-farm care things in your face, and we'll see that. Do they have a copy of the?
Yeah, they do.
So you actually have a copy of the scoring sheet if you want to take it out. The real comfortable, or the really colorful one, or when we get to it, you can take it out. But basically, in that scoring sheet, the non-farm cares are listed, and it gives you the opportunity to look and say, am I doing this, am I doing this, am I doing this? So different than having a separate education piece in a separate document, it's part and parcel of the scoring. And that's, to me, the biggest strength of Eat, Sleep, Console, is that it pairs the non-farm care with the symptoms and forces the non-farm care. I think what we see on this slide would be fine and would function just like Eat, Sleep, Console if you could marry the non-farm care with the symptoms. And for some centers, they're doing that because they're really comfortable with Finnegan. They're not ready to change. And I think there's advantages to doing it that way. It's just what we found, and what I think a lot of centers found, is when you are doing the additional training, you're teaching scoring separate, then you're teaching non-farm care separate from talking about prioritization. And what Eat, Sleep, Console does is put them all in a nice little package. Okay, next slide. Okay, so she did a few cycles. The first cycle was the non-farm care bundle. So they introduced non-farm care, which is comfort cares. So just those words I'm using interchangeably. Comfort care is non-farm care. Prenatal parent meetings, engaging parents in non-farm care. That was the first thing they did, and that's kind of the first thing we did too. And then they changed their Finnegan to prioritization. As I said, performing the huddle and looking through things. The other thing I guess that's important about Eat, Sleep, Console, the third thing that Elise is doing here, Dr. Watchman's doing here, is the huddle. So the huddle is really important too, because what used to happen at our center, still kind of does, and probably at many of yours, is you get a call from a nurse who says, okay, I've had 3 9s, and you say, okay, send them up, we'll start treatment. But what the huddle is you come down after 2 and you say, okay, let's all get together and see how it's going. And we'd have the nurse, the mom, and the provider. It could be a practitioner or hospitalist or the attending, whoever happens to be there at the time. But you get 3 minds together and say, how are we doing with the non-farm care? What have we tried? Let's try this. You just get a team approach. It's not, and you get the different perspectives, and you get mom to buy in or not buy in, at least know where they are and be part of the decision making. So that's the other important thing about the package, the Eat, Sleep, Console package, is the huddle. And that can be grouped with what they did in their first project, which is, making it part and parcel. But again, the Eat, Sleep, Console package is the huddle. So that what it does is you have the scoring, you have the huddle, and you have the non-farm care on one sheet, prompting you what to do and forcing you to have the huddle. Okay, next slide. So this is a really great slide. I know it looks a little busy, but basically the top line, can you just trace it on the top line here? The top line says kind of what was happening before they did anything. And when they put into place their non-farm care bundle, which is their comfort cares, symptom prioritization, parent education, including their huddle, and staff education, their mean of percent treated dropped significantly. And then they did some other things and it didn't change at all. So the point of this is they actually put right where the pointer is now, Eat, Sleep, Console tool started to be used, and nothing changed. But they'd already pretty much implemented all the things in the Eat, Sleep, Console toolkit, but separately. So what this demonstrates is you can do those all separately and get the result you want. But now that there's a bundle created, because they created the bundle, the Eat, Sleep, Console care tool, I mean, it's easier to use that to teach. And so you could kind of replace that if you go back to where the non-farm care. So if you were, back here to the, So if you were just starting, you could, if you want to embrace Eat, Sleep, Console, you could put Eat, Sleep, Console toolkit right there. And what that would do is give you all the tools and the functions to do what they did, the non-farm care bundle, prioritization, education. Or if you don't want to put the 2 in place, you're getting pushback, you could just do those things separate and not call it Eat, Sleep, Console. But if you do those things, you're going to get a result. Can I have a thumbs up or a thumbs down? What? I don't see any thumbs yet.
I saw live thumbs.
Oh.
I don't think they can put thumbs down, which is kind of weird.
There's a thumbs down.
Oh, is there? Okay,
There is
I
a
just can't see it on.
Thumbs up. There we go. I got one. I got some thumbs up.
To get the thumbs down, you hover over manage participants, then you look for your own face.
That sounds hard. Thumbs up if you agree, clap if you don't agree. Well,
That
that's
works.
good. Clap, there's clap, so you can clap. Okay, we're good. Chat in if you need any more words on that, because again, this is kind of the important information. Okay, next slide. So now we're going to compare a little bit of the work that they did to look at how Eat, Sleep, Console compares against Finnegan. But keep in mind that this is not a research proven tool. In fact, there's a research study happening that Shawnee Mission and KU have enrolled in, where they're actually keeping some data. I'm not sure it's answering all the questions, but at least it's a systematic research study. What we're doing is going to be QI, and if you put this into place, we're expecting you to keep the same kind of data you've been keeping and report that back so that we can share that data. So the way that we have access to all of this through the developers of the tool is that we've agreed to give them data back. So this isn't necessary. Eat, Sleep, Console has not been deemed a best practice. There's been a fair amount of QI that have shown nice results. It's very culturally based, and you can't say that it's proven at this point. So if you do put it in place, you really need to keep good data to decide in your culture, has it made a difference? Some of the unforeseen consequences or negative outcomes that can be related to it that they've seen when they tried to validate the tool is that babies can be dismissed too soon or not treated when they needed to be treated. So the risks with that is increased readmission or failure to thrive. And as they were validating the tools, we're on the third or fourth edition? Third. So we're on the third edition. So after they've been validating the tools for Eat, Sleep, Console, they've been doing that informed by some of the QI, which has shown that in the first couple editions, babies were more likely to have failure to thrive than babies who weren't managed by Eat, Sleep, Console, presumably because they were maybe dismissed too soon or they weren't treated, and maybe they needed to be treated. So that's the biggest risk. So it's under treatment, decrease in length of stay that may not be helpful. And some of the people who are antagonists to Eat, Sleep, Console, and there are those people, feel like it's a very dangerous thing, and that not being treated appropriately has a bigger long-term effect than getting out of the hospital 2 or 3 days earlier. So it's important that you know that and you keep this data and look and make sure that if you put this in place, you're doing it in a safe way and that babies are being managed in a way that they're not going to be readmitted and that they're going to continue to grow and not suffer from significant withdrawal at home for weeks, which could have a bigger neuro impact. So it's weighing kind of the potential risks and benefits, and with any QI, of course, you have to look at potential risks. So having said all that, I'm going to give you some of the information that supports that this is a good thing to do. And so using a standard Finnegan criteria with 3 scores greater than 8, 2 scores of greater than 12, 50% in these studies that are quoted below at the very bottom received treatment. And a score of 7 or less was not treated. From Finnegan. They could recover, but above were treated. And the other thing that I learned I guess it was this winter that was fascinating. I went to a conference with Finnegan. She presented, and she talked about, she actually had her first NAS baby in 1969, and I remember that because that's the year I was born, and it died. And a lot of them died, most of them died. And on autopsy, they had big holes in their brains. And they didn't know what the problem was. They didn't know it had to do with drugs necessarily. They didn't know anything. They just knew all these babies were dying. And as they figured out what it was, they came up with these rules because so many of the babies died and it was so important to treat them. And the thing I think to think about now is the natural course of this disease has changed dramatically, and babies don't die of NAS. We can support them. And so again, it's time to kind of look at things differently. So it was a really interesting perspective, and it helps me understand why my initial training in the 90s was every baby at risk goes directly to NICU and gets on a monitor, which was, how I was trained in the 90s. And, now we don't even monitor them necessarily. We just let them be and watch their scores. But I think that even in the 90s, that was a leftover from what Finnegan had seen in the 60s and 70s, which was they could just up and die. So of course they had to be on monitors. So the disease has progressed, and with the progression of the disease probably comes the way that we treat it. So with that in mind, the treatment and length of stay, length of treatment depends on the severity of the withdrawal and how many substances are exposed to the setting, all those kinds of things. And the average length of stay at the time that these studies are done, which are at the below, which is looking really 2012 to 2000, probably 15-ish. The last study that was published in 2018. The average length of stay, it was 16 days for all infants and 23 days for pharmacologically treated. And so that's where one of our goals, the KPQC, is to decrease that. And I think we're getting there a little bit sometimes. Betsy's making a horrible face, so maybe it's not true. Sometimes we're getting there, and maybe we're not. Okay, next page, please. So where'd you go? What are you doing? Oh, okay, so there we are. This slide isn't as beautiful. In fact, you might not be able to see it at all because I can't. But what it shows is Grossman's experience. He's a general pediatrician. And actually, just another interesting piece of history. So Grossman was kind of thinking about a better system at the same time as Wayland was. And Watchman was kind of interested in it. And they happened to meet at the airport after a PEDS meeting. I can't remember if it was PAS or what it was. And they started talking about what they were doing. And they were all kind of independently coming with some other ideas of how to treat NAS, because we were all involved with Vaughn at the time and really trying to think through what we were doing. And Betsy and I was involved with Vaughn at that time too. And so kind of you see different studies from Grossman and Wayland. And then what Watchman did is she's an academic neonatologist. So she had the time to really kind of look at more discrete data and kind of really do the science behind it. And so you see these different studies, but culminating in kind of some work they did together. So this was at the same time, Grossman was doing his own thing, and they put in their Eat, Sleep, Console at the arrow. Can you put the long arrow with it? Over. No. This is standard. So they avoided the direct admits, and they got a little drop, and then the novel approach right there is where they introduced their version of Eat, Sleep, Console. And so they have a market drop off with that. So they would say, well, Eat, Sleep, Console decreased the percent treated, but Watchman would say, well, we got that exact same response, but we didn't use Eat, Sleep, Console initially. We just used these elements of it. So again, you can see that it doesn't, they used the actual first package and they had a drop. But if you did the things in the package, you could also have a drop, is my point. But this, if you just look at this study alone, you'd say, oh, Eat, Sleep, Console is a magic bullet. We all have to do that. And now you guys know that's not necessarily true. But the package of what it proposes, which is mirroring the huddle, discussion with the family nurse and physician, the comfort cares, and the symptoms and the prioritization of those symptoms is what makes the difference. Are we all good with that? Anyone? Come on, use your thumbs. Okay, I see a few thumbs. Keep going. Okay, so this is those two slides together just to drive it home in case I haven't. The top is Watchman's, where they had their improvement before Eat, Sleep, Console bundle. The bottom is Grossman, where they put the bundle in place and had the same kind of drop. But you can see the drop is almost the same. Okay, and next. Just as an aside, it really bums me out that Betsy and I didn't publish our work because we had the exact same result with what we were doing. We have beautiful graphs just like that. We were just too busy doing QI to write it up. Okay, so I'm moving you guys down a little so I can get this. So this is, I think this is really interesting, and I kind of like this. This is looking at comparing Eat, Sleep, Console to Finnegan kind of head on. So what they did in this project, and again, it's 300 patients, so it's not a great research study. It's not even a research study, it's a QI project. But what they did is looked at if they scored both at the same time, what would they be instructed to do by the scoring? So 300 patients using to the left, the 17 days, 6%, morphine started or increased using the Eat, Sleep, Console approach. And out of those 17, if you did the Finnegan, 2 out of the 17 would say, no, you don't actually need to have that. And then of those 2, actually, later, they increased and actually needed morphine. And so the 15 out of the 17 that agreed also said predicting. So what this would say is, if you use Eat, Sleep, Console, the 6% that ended up needing to be treated according to Eat, Sleep, Console, all of them ended up needing to be treated according to Finnegan, but 2 of them, it just took a little longer. If you look to the other side, to the right as you face the screen, house right, if you will, stage left, the 279, the 94% who morphine was not started using the Eat, Sleep, Console approach. 78 of those, the Finnegan disagreed. Finnegan said, actually, according to our scoring, you should do morphine. And then, if you follow those a little bit further, 68% of those ended up decreasing and not needing it. So they weren't treated. Eat, Sleep, Console says don't treat. Finnegan says do treat. They weren't treated. And then with further assessment, Finnegan also said don't treat. And then, but 23 out of the 73 did increase and eventually needed treatment. So what this is telling you is the risk of Eat, Sleep, Console is not, it's not catching people who need to be treated, it's under treating. And we already know that because we talked about it already. And then of those 201 of the 200 the days, that's a different number, I'm not sure why, but they also predicted no morphine to be given. So this is just kind of a demonstration. And some people would argue, I have a graph I don't think I have in the slide set, but the risks and benefits of undertreating and overtreating. And the problem is we don't know which is worse, overtreat or undertreat. You know, we've behaved in all these years that undertreating was the worst and that they could get seizures and die, and that was the worst thing that could possibly happen. But now we're realizing if we undertreat, we can treat later as long as we watch them long enough and they don't get seizures and die. So it just bears the question, which is the worst evil? Is it worse to be in the hospital longer and be on narcotics longer? Or is it worse to have some that are undertreated? So, okay, next slide. Okay, this is your beautiful tool that will become your best friend. And you guys should all have that tool. And it's super busy and a little overwhelming, but it'll become a lot easier as you get used to it. But what you see is that at the top.
Attention please, high wind warning is in effect for Johnson County until a half hour from now. Gusts are expected up to 70 miles per hour. Attention please, high wind warnings are in effect for Johnson County. Wind gusts are expected up to 70 miles per hour.
That was really hard for her to say. Did you all hear our wind warning? Okay, sorry. So, so this tool, although it looks confusing, once we walk you through it, you get used to it, it's not. And once you study it and really understand it, it's a good friend. So the first 3 areas, the Eat, Sleeping, and Consoling, we're gonna go through how you rate those, but that's basically your score. And then the next part, which is non-farm care, gives you prompts about what you can do, and you can mark them off so you can keep track of how you're doing. And then at the bottom, it says, do you need to have a huddle? Do you need to have a full huddle, a partial huddle? What are the next choices? That's the front. And then the back is to the right. That gives you the definitions of how you score. And we're going to drill those into you. So eventually you won't need to look at that. But for now, you see that that's there. And I think this is where Betsy takes over. Is that right? Okay.
So what we're going to do now is go over the tool in depth so that you guys can be comfortable with it. And then when we, like I said, when we get back into the sim labs, we are going to make you feel really comfortable with it. You guys will have to check off with us, and we'll do videotapes of you guys doing that as well. So it's a functional model. Is the baby meeting milestones to be and it's looking at basic functions. So the 3 basic questions: can the baby eat, can the baby sleep, and can the baby be consoled? Which everybody thinks that this tool is just going to be really easy to use. You just breeze in, you ask these 3 questions. But when you really look at the tool, it's not that easy. You really are having an in-depth assessment and conversation with the parents, with the mom, each time you're using it. And the good thing about that is each time you are in that room, you're really reinforcing comfort measures. So when you're using the Finnegan, you're running in, you're looking at signs and symptoms of NAS. And although we're really trying to do comfort measures and teaching our staff comfort measures, sometimes we're not that good about looking at the whole big picture. This just brings everything together. It really makes you sit down and focus on those. So when you look at, like I said, it's, so I want to move them. There we go. Sorry, I had to move you guys. So when you look at it, it incorporates the eat, sleeping, and console behaviors. It looks at looking at non-pharmacological interventions, or your NPIs, as they will use that abbreviation. And it's a clustering of care with your staff and with your parents. Each assessment, like I said, is an opportunity to reinforce your comfort cares or your non-pharmacologic interventions. It provides an avenue to educate each time, which I really like that. Your assessments are done with the infant's waking and feeding times, which is no different than the Finnegan should be. So every time you do your Finnegan, it should be after the baby's feedings. This is the same thing. So it really is not a different concept in that. The infant's going to be assessed on eating, sleeping, and consoling, and we're going to go over each of those. We're going to look at the severity, but you really need to tie in the symptoms of NAS. So if you think that you're just looking at eating, sleeping, and consoling, that's not the point. You really need to know your NAS symptoms to know if those are causing a dysfunction in the eating, sleeping, and consoling. So you really have to know, like Dr. Jackson went over, your symptoms to know if those are the root of not being able to eat, sleep, and console. And then you need to know that your non-pharmacologic cares are maximized. So as far as eating, and these, if you look at your tool, if you have your tool out, all your definitions are going to be on the back side of your tool. So it's a really handy cheat sheet to have. A lot of centers will have this on their computer when they go live with it, but it's a nice tool just to have copies of when you take into the room, and you can show the parents what you're doing, and it helps reinforce those with the parents as well. So as far as eating, if it takes greater than 10 minutes to coordinate a feeding, after showing hunger cues due to NAS. So if the baby's jittery, if the baby has increased muscle tone, if excessive crying, all of those things make the baby not be able to eat. If the baby is unable to breastfeeds less than 10 minutes or an age appropriate duration. So if the baby's 6 hours old and is already showing signs of NAS and he's unable to eat more than 5 minutes, I mean, sometimes you're not going to expect a early baby within the first 24 hours to be able to breastfeed 10 minutes. So it's an age appropriate duration. An alternative feeding route like bottle feeding is less than 10 mils due to NAS symptoms, like within that first day. You know, day 3, you would expect that an age appropriate volume. So day 3, less than 10 mils is probably too small of a volume. You'd expect, you know, more than like 30 mils or so. So it's always an age appropriate volume. So that's what you have to think about. So, so on your tool, you would, you don't want to indicate yes if the poor feeding factors are non-opiate related. So if they're preterm, if they have transitional sleepiness. So in that first 24 hours of life, you know, they're that awake time in that first 6 hours, and then they kind of sleep a little bit more. You don't want to relate it to that. Spittiness in the first 24 hours of life, you know, if they're a C-section baby and they have extra fluid. Inability to latch because of infant maternal anatomic factors. You know, there's just a discoordinated size going on. So optimal feeding. The baby awakes at hunger cues, feeds until it's content without any limit placed on duration or volume. So it's an easy, coordinated feeding. Feedings are encouraged for at least every 3 hours. So optimally, you want 8 to 12 feedings a day. An infant may remain sleeping past 3 hours only if there's no feeding difficulties and only if there's no excessive weight loss. You want to closely follow daily weights, and you want to look at providing increased volume or increased caloric density if you have unexpected weight loss. And they're really, you really need to watch this because in the earlier versions, they did have some extra weight loss and babies were going home and then they were finding that there was increased weight loss. So we want to make sure that when we're doing Eat, Sleeps, and Consoles, these babies are not excessively losing weight and they're not struggling to eat. Sure.
So just about the increased caloric density, there is a little work. I wouldn't say that it's best practice, but there's been some experience that when babies are eating too much volume and having excessive stools or having too much weight loss, that adding caloric density can help them feel more full, sleep a little bit better, not have as much weight loss. There's no good evidence that other formulas help with that. So we have a lot of people within our group wanting to switch to a sensitive or a formula that's lactose free or whatever. I think people incidentally have talked about that being helpful, but there's no real collection of data except for using increased caloric density. And I think somebody just asked what's considered excessive weight loss. And I think it's depending on the day of life. So Heather said, what do you consider more than expected, greater than 10%? It depends on the day of life. So, you know, after day 1, if they've already lost 6%, that's too much. You know, on day 2 or 3, probably 10% is too much. But you really want to nab it before it becomes too much. For me, my experience is more about using the caloric density is more about when these kids just can't seem to get enough food and they're eating themselves into diarrhea and water loss stools. Sometimes adding a little more calories will back off their total volume and help them sleep better. And then you can do that in different ways. If you're using breast milk, you can add breast milk fortifier to it. A lot of hospitals don't allow powder because of the risks that the powder is contaminated. I don't know how all you guys are, but if you're allowed to add powder, you can add just normal, like Similac powder to breast milk, and there's recipes for that to make it higher calorie. You can add NeoSure powder. You can do a NeoSure feed. There's all different ways to increase the caloric density. Just to know that that's an option.
So, like I said, optimal feeding for breastfeeding is that the baby's going to latch deeply and sustain active sucking with pauses only. If the baby has breastfeeding difficulties, you want to, of course, assist directly. Hand expression prior to and during feedings, and consult lactation. So anything to help these babies with their feedings. Bottle feeding, effective coordination and suck, swallow without gagging or excessive spitting up. Feeding difficulties, you want to assess for altered nipple shape and flow, chin support, altered position, Dr. Brown's bottle, side laying, pace feeding, if you have speech therapy or occupational therapy, that is great to use as well. But just helping the parents with feedings as you can, is awesome too. So a lot of times these babies are just poor, uncoordinated feeders and just really need extra help. Okay, so sleeping. Sleeping's definition is if a baby sleeps less than 1 hour due to NAS. So again, fussiness, restlessness, increased startles, tremors, excessive crying, anything like that would be scored as symptoms for NAS. So you don't want to score the baby for things like cluster feeding. This is a tool that allows for cluster feeding in those first couple days of life. Whereas the Finnegan, if you remember, scores against babies that wake up every couple hours to feed. You would get a 2 if the baby woke up at 2 hours or 2 hours to feed again. So it's a nice tool because it allows for cluster feeding. Interruptions in sleep because of a newborn testing. So we've taken the baby down to the nursery to do his labs for newborn screens and stuff like that, and he comes back fussy. Nicotine and SSRIs. So remember, these babies that have exposure for that can be excessively jittery. They can have signs and symptoms of withdrawal or it's more of a toxic or a toxidrome. So it will get better as further out from symptoms. So you kind of just have to help them through that. So, but that, is still a symptom of withdrawal. So that's kind of a hard one to filter out. So, but just looking for true symptoms of withdrawal to score against. And then inability to console. And so this is if the baby cannot console within 10 minutes and stay consoled for 10 minutes, despite infants' caregivers' best efforts at non-pharmacologic interventions. So this is where you're really having to help reinforce those non-pharmacologic interventions, and that's what the beauty of the tool. So you don't want to score yes if the like circumcision pain, anything we've done to the baby, and then non-caregiver responsiveness. So just let me finish. So at that point in time, you could say yes, the mom is ignoring the baby, and you really would need to reinforce that the mom needs to feed the baby, really reinforce those non-pharmacologic cares. And then sit down and have a good conversation with her. So that one kind of is a hard one, because it's the mom, the way the scoring tool was built, they use mom's best ability, but it's hard because you really have to make sure everything is maximized before you'd ever want to take a baby up and put them on pharmacologic treatment. So you have to make that mom or parent the best at giving those pharmacologic cares, and it's our job to make sure that that environment is absolutely maximized. Go ahead.
So sorry to interrupt you. So I just wanted to clarify, this becomes confusing when we do the simulations, and just to make sure we're all on the same page, because the question is 10 minutes despite provider's best effort. And if at that moment that's her best effort, baby's crying, but she did a bad job, but that was the best she could do at the time, I would say you score yes. It doesn't mean they need to be treated, because what happens is you have a huddle when you have high scores. You don't necessarily bring them up to be treated like you would with Finnegan. So I think it's important for record keeping that the answer is yes. He couldn't console, despite mom's best effort. So what did we do? We educated mom some more. And so then you go into your comfort measures and you mark what you did, which is you educated mom some more. And another good reason to have a huddle is then everybody's in the room with mom and we say, okay, so he's not consoling, let's talk about what's going on. And we realized that, one of our scenarios, I don't know if you've watched the videos yet, but the mom leaves the baby in the crib because her mom told her that she shouldn't spoil it. And so the baby's crying, but she has him in the crib and she's kind of shaking the crib, but she didn't take him out of the crib because her mom, the grandma, said, if you hold him too much, you're going to spoil him. So at that point, that was her best effort. It wasn't my best effort, but it was her best effort. It's a score of yes, he didn't console because that's what happened. And now we have a huddle to discuss it and change things. So I think people tend to not want to say yes because they say it's not the best effort. But what that is basically saying is they're not consoling and the mom's trying right now with what she has. And then our job is to give her more and help her be able to support more. Some of the questions we've had outside of education is what about, culturally, if there's a cultural barrier and we just can't educate them the way that they need to be educated. Well, again, it's their best effort. We do our best, they do their best. And if, you're not consoled, you're not consoled. And at some point you need to do something different. But the big part of what Betsy was saying is, our goal is to have the resources to really train moms and help them to be able to do what would be better than their best maybe, and really understand, that they need to do these non-farm cares to make a difference. Does that make sense? Did you agree with the scoring?
No, I agree with the scoring. It wouldn't necessarily, when we get into the huddles, you're going to see that there's two different types of huddles. There's going to be a huddle with the nurse and the mom, and then there's going to be a full huddle where you bring in the provider, the nurse, the mom. So if this is one where it's non-responsiveness to the mom, you don't necessarily have to call in your provider at 2:00 in the morning for that type of huddle. That would be one where you could do the mom and the nurse and really reinforce those providers. And you're going to see when you start to use this tool, you're actually doing a huddle almost every time. So if that makes sense.
Yeah, and every time you're doing some education, but again, I agree that the first time, and maybe even the second time, you wouldn't need to call the provider. But if the third time the baby's still not consoling, and the mom's still not doing what she needs to be doing, then it may be time to call the provider to reiterate.
Correct. Well, you have to call the provider on the second time, no matter what. Okay. So there you go. Yeah, there's a safety net there. So, okay. Consoling support scale. So there's a scale built in on your thing where you have the ability to console on the own. It's a 1. 2, you console and stay consoled within 10 minutes with support. You may be swaddling, you may be doing skin to skin, things like that. Or 3, it takes greater than 10 minutes and the baby still can't stay consoled despite non-pharmacologic interventions. So if you score a 3, then that's the same as like a baby scoring a yes on unable to console. So if you score that as a yes, then that baby would need a huddle. So your non-pharmacologic interventions are very much like everybody's used to: rooming in, parent caregiver presence, holding by parent caregiver and cuddler, skin to skin, safe swaddling, so below the shoulders, optimal feeding, quiet, low light environment, non-nutritive suck, rhythmic moving, visitor limitation, clustering of care, additional help. So this may be like a cuddler program if you have one of those. And then the one that we don't think of very often is parent caregiver self care. Giving them permission if they are just at the edge of their rope to walk away. Why don't you let me hold your baby for a while and you go take a walk? Why don't you let me get a cuddler so that you can take a nap? These babies can be very challenging, and if a mom's in the room 24 hours, 7 days a week, she's gonna wear out. So really making sure that she actually is taking care of herself too. And that's one that we don't often think about. Okay, so both of us. So when you look at the caregiver huddles, this is where we were talking about the provider versus not provider. When you have a parent caregiver huddle, it's when they first score a yes out of one of the 3 items, like not being able to eat, sleep, or console, or a 3 on the consoling support. That first huddle would be between the parent and the caregiver, or caregiver and the nurse. So you would do a bedside huddle with them. You'd really reinforce those non-pharmacologic cares. See what you can reinforce, really help that mom alter that environment. If they're having a hard time breastfeeding, get lactation support, anything you can do to assist that baby, having, tube assist, anything like that. The second time you have a yes on the eat, sleep, console, so you really reinforce those non-pharmacologic cares as best that mom can do. If you have a second yes, at that point in time, you're going to bring in that care provider. So it's not like we're going to ignore it. We're really reinforcing it that first time. And the second time, if we're still not having success with it, mom might have a mental block. At that time, we need we'll really ramp up that huddle. We're going to bring in the physician. Everybody's going to meet together, and we're going to come up with a plan of care. We're also going to look at those signs and symptoms, and we're going to determine if pharmacologic care is needed at that point in time. Not that you're not doing that in the first huddle, but you're really going to bring your physician or your provider in too. So.
Okay. Hey, before we go to this graph, you're going to go to the graph. We've been kind of breezing over a cuddler program. It was in all the previous slides of best practices with those studies I showed. Does everybody know what a cuddler program is, or heard of a cuddler program? I'm seeing a few nods. I'm seeing a few blank stares. So basically, it's a program to have people come hold babies that need to be held. And it's a lot harder to put that into place than one would think, because it has to be vetted through the hospital, and for us, it had to be part of our volunteer system, but separate, and they didn't want to make it separate. And but it's a really good thing to do, and I think we have some presentations about that, don't we? On our cuddler program? No, we don't. So that might be a future webinar, but if people are interested. But that it's worth a lot. There's a lot of people in the community who want to volunteer for that. We have some retired nurses, retired other healthcare providers, sometimes just people who want to hold babies. They go through education. It's restrictive of what they can do. But for babies who are experiencing withdrawal and whose parents can't be there all the time, having somebody hold them makes a huge difference. And it's better for the family, it's better for the nurses, it's better for everybody. So if anybody after this conference wants to talk more about how to do that, I think it's an important part of any NAS program. You know, we keep referring to it, but it is its own project, and having it, I think, is the only way to optimize care, whatever scoring system you use. And the huddler was provided to be done over the phone.
Yes.
Yes, yeah, definitely. You can do the huddle over the phone. It's whatever you can do.
I'm getting good at. We're also getting really good at the virtual world, so you can bring him in by iPad, Skype.
Well, it's got to be HIPAA compliant. That's the only problem.
Well.
But yeah, you can definitely do it over the phone. You can do it if you have a compliant system. Just getting more brains together in one room.
Yeah. So here's the graph.
Okay, so let's see. I got to move you guys. Okay, so you're doing your scoring and your non-firm care, and then you end up with one of the problems. You're not eating, you're not sleeping, you're not consoling. The big question is this related to NAS? So that's when you start looking at your other signs that we talked about: excessive rooting, uncoordinated suck, body-aiming, increased heart rate, interfering with feeding, tremors. Are they having these other things that we know are NAS symptoms that we think those are why they're not eating, sleeping, consoling? Is the timing consistent with withdrawal? So that's important. If it's the first hour or two, it's not consistent with NAS, and it's probably due to her nicotine toxidrome or whatever other medication she might be taking. So if a baby's not doing well in the first 4 or 5 hours, it's probably a toxidrome from cigarettes is the number one, but cocaine, other amphetamines. And what it is, a toxidrome is just expressing that the effect of the drug. It's not a withdrawal process, it's expressing the effect, and it goes away. So if you're seeing these things in the first hour and you can support them through it, it should go away. And then that would not be NAS. And then do you have a video chat via doc? I don't know that we do right now. There's a question just came up, is do we have a video chat? The question just came up, do you have a video chat via Doximity with patient that is compliant? I don't know that we do right now, but those are the things that people are looking into for the huddle. That question just came in, sorry. Sorry.
What? I mean, Dr. Jackson and I work through Children's Mercy, and we do like telemed with one of our hospitals.
Yeah.
So.
Right. I mean, there's different systems, and we can look into that and help you look into that.
Yeah.
At the end. So then the next question is the non-pharmacological treatments fully implemented? The other thing to think about on this one is if the timing is not consistent or you don't see these other things that reflect NAS, it could be something else. And that's one of the things that we worry about missing too. And you probably have all experienced it, I have, where people are convinced, you know, this baby's not eating, he's got NAS, and really he's breathing fast and he has lung disease, he has pneumonia, he's an infection, he's got, you know, he's still at risk for all the same things that another baby would be at risk for. So if they're not eating, sleeping, or consoling, but there's no other signs of withdrawal, or they're excessively sleeping, they're not eating, but they're excessively sleepy, or they're not consoling, and they're irritable. You know, you also have to think about, you know, does he have meningitis? Does he have an infection? Does he have something that we'd worry about any other baby who wasn't at risk for NAS? And sometimes we get in trouble if we're not doing that. And that's something important to consider. So I can't see the bottom of this screen. So then, oh, there you go, thank you. Oh, no, go back. Yeah, that's it. Okay. So if the symptoms are consistent with NAS, the time is consistent, and you've maximized the non-pharmacological treatment, you perform a full huddle, reviewing the questions as above. If the answer is no, then you have a parent caregiver huddle to review symptoms and non-pharmacological optimized care. And contact provider symptoms are thought to be to another etiology. So that's the thing I want to emphasize on this slide is, just the people need to use their critical thinking. It's not just a yes, they're eating, sleeping, consulting. They have to think about what are these consistent with? Are there any other signs of withdrawal? If they're not eating, sleeping, consulting, but there's no other signs of withdrawal, then it's probably not NAS. And again, that's why I emphasize that little sheet in the beginning to know what the other signs of withdrawal are. And then of course, if they're having apnea or seizures, and you think it's related to NAS, of course they need to be treated, and you don't talk about it anymore. You just treat it. And if they're having apnea seizures for another reason, of course you deal with that. Okay, the next slide. And then this is that card again. So that I talked about just a second ago. That's why it's important to have this with you. Because if you say, no, he's not doing one of those things, but he's not having any other symptoms. So he's not consolable, but he doesn't have any other, no, increased tremors or jerkiness or sneezing or anything else, then it's probably something else. It's probably not NAS, because it doesn't present just with the sleep and soul problems. Those are the continuum of when they express themselves. Okay, so perform full care team huddle. Are the symptoms NAS? We kind of talked about those, some of those things that might be. Is the timing correct? Have we optimized care? If no, determine etiology of symptoms and implement appropriate management. So just again, don't assume it's NAS. Reinforce education to improve non-pharmacological care and continue review. If the answer is yes to those 3 questions, then we initiate treatment. So this is a little controversial too. Some centers are using a PRN treatment. That's really kind of new, because for those of us who were involved with Vaughn in 2012, 13, 14, we were convinced that PRN treatment wasn't the right thing to do based on the research at the time. The data and the pharmacological contribution convinced us that PRNs weren't good and they made things worse. And now there's some data coming out to say that PRNs might be good if you use them in this kind of system. So I think the problem was when they first looked at it, there wasn't a great systematic approach. There wasn't Finnegan, or modified Finnegan, there wasn't huddles, there wasn't peer education, there wasn't sleep consult. It was pretty haphazard. And what they found was if you haphazardly gave medication, PRN, on top of kind of a haphazard process where you didn't have a lot of good education, that wasn't a good thing to do. But what we seem to know now, it's not, I wouldn't say it's considered best practice yet, but what the data is seeming to show us is that if you have a really good system where you're assessing patients well with educated people with a system like Eat, Sleep, Console or Prioritize Finnegan, that PRNs may be beneficial, because if you look at the natural course of withdrawal, it kind of peaks, stays high for a little while, and then comes down. And with the way that we have been treating, we've started and we're not probably weaning fast enough. And what people get stuck in is, oh, it was his first good day, let's not wean. He's had scores 8s and 9s. He's finally having 6s and 5s, but it's his first good day, so let's not wean. But when you do that, you're causing the problem. You're giving medication what's not necessary. So you're contributing to the dependence, and it may prolong things. The evidence is suggesting, based on what we know about this medication, which is opposite of what we thought previously. Just like in any good medical story, over 10 years, it completely changes. And it's hard for those of you who are treating now, it's hard to know when to wean. And so with the PRNs, it really kind of forces you every time to decide, do we need to keep treating? Then it brings up the question, if you're getting PRNs, you need to be in the NICU, where do you need to be? And I think if we haven't done a webinar on this, we probably need to. Have we done a webinar on treatment, medical treatment?
Yeah, we did one.
And did we talk about the PRNs?
No.
Oh, we did a webinar about treatment, but we didn't talk about PRNs. So that might be something for the future too. And I'm not going to go into all of it now, but that is a possibility. And so if you're doing PRNs, you continue to score to determine further medication. If you're not doing PRN, you still continue to score to decide about weaning. And one thing we do know is we need to wean faster. So if we start medication and within 12 hours our scores are acceptable, the baby's now eat, sleeping, consoling, we need to wean. We need to not wait till the morning. And so that's the reason to keep watching just as closely and keep optimizing non-farm care, because you want to wean as fast as you can. And what sometimes happens is babies get put in the NICU, the mom doesn't come up, you give them a bunch of morphine so they sleep for a while and say, well, he just needs to rest. But the longer you treat, the longer you're going to treat physiologically, pathophysiologically, not just logistically. Because the longer you treat, the more relegation you have, you're extending the dependence. So if a baby needs treatment, we still need to keep in effect all of our best non-farm care. And if we have to move the baby, we want to move the mom with the baby. If we can not move the baby or move him for a short time and get him back with the mom, that's the most desirable situation. We need still all the things you're doing before to keep doing so it can wean as fast as possible. Okay. So this is just your sheet again.
Okay.
And I think, are we ready for a break?
No, I need to talk.
Oh, okay, Betsy can talk for a little while.
So, actually, no, they get to go to break.
Okay.
So what we're gonna do next is, ooh, we're actually ahead a little bit of time. So what we'll do next is we're gonna talk about the simulations and stuff like that when you come back. And then what we'll do is when you come back, we're gonna do a video of the simulations and we'll talk through some written simulations, and then we'll talk about implementation of the tool, and then we're going to do some breakout sessions. So why don't you guys take a 10 to, or come back in like 15 minutes, and then we'll start back again. This will give you time to run to the restroom and get a drink and stuff like that. So it is
about 11 o'clock, Betsy, if everybody.
Yeah, that'd be great. It's and did you put the PowerPoint in the chat?
No.
Oh, okay.
I've been sending it by email to the people who send me their email addresses.
Excellent, thank you. I couldn't do it because my computer's tied up.
Yeah, sure.
Put it in the chat, Anne, so everybody can pull it down?
No.
No? Okay,
So,
never mind.
Great. All right, we will see you back at 11.
All right, everybody, it's 1 minute until 11 o'clock, so we'll be getting started again in 1 minute if you're ready to come back. Quinlan, there's just a little bit of teaching we're going to do before we run that video.
Okie dokie.
All right. Ready to leave them up.
I'm watching you rearrange the room.
Oh. Oh, I felt like they were too close to me. I'm breathing on them.
They're at 95.
I know. I don't want to breathe on them. They've got Anne and Quinn have some kind of.
She sent me one. I couldn't figure out how to put it on my background.
I'll get pushed away.
They ran away and they're not coming back.
You know, what I was going to ask before we left is to have them chat in how it's going and what they want better, or maybe we should ask them.
Okay.
Like if it's going, if something that could make it easier for them.
Okay.
So we got some chats here.
Oh.
No, it's just the mail.
All right, it's 11 o'clock. It's time to get started. This is Anne, and again, I'll remind you that if you'd like a copy of this slide deck, you can just chat into me your email address and I'll send it right off. And so welcome back. Welcome back from break. Over to Dr. Jackson and Betsy.
Okay, so the first thing we're going to go through is the objective structured clinical exam, and this is just, or OSCE for short, and this is just kind of how you're going to go through the Eat, Sleeps, and Consoles assessment, and especially when we do return to sim labs. And it's just kind of a good tool to how to use and use the Eat, Sleeps, and Consoles, and just kind of what we'll look for in the sim labs, but just kind of a good overall way to work with your parents and your moms. But when we do go into the sim labs, because I think that we'll just meet in person and not do much of a class session when we come back. So when you first meet, what we're gonna do is we'll perform a sign out, meaning we're gonna give you a little bit of a brief history before we go into the sim lab. We'll tell you about the baby scenario and stuff, very much like the case 1 through 4 that I gave you in your left side of your handout. It's always important to introduce yourself to the parent, of course, and you do that in day to day when you first come on your shifts and stuff like that, and your clinical role to the mom. You want to project your voice when we're in the sim lab so that we can hear you, especially when we do recordings. We always want to sit down at eye level with the mom, and that way I find it's more non-judgmental. You really show compassion in doing that. You show like you want to work with them, you want to understand them. It just shows a lot more compassion to them versus standing up and staring down at them. It leads to just more of an open conversation. We want to ask open-ended questions, not yes or no. Is your baby eating? Yes. Is your baby sleeping? Yes or no. Just ask those open-ended questions so that you'll get answers. How is your baby eating? How long has your baby been eating at the breast? How many minutes on the left? How many minutes on the right? Just questions that are really going to get those answers that you need. If your baby's not feeding very well, what kind of problems are you identifying that are interfering? Well, he's really crying and I can't get him to settle down and latch on. Things like that. Those are things that you're looking for. Clarifying questions. In your packets, you will have case diaries that you can look at, especially when we're doing the simulations. And you'll want to review those with the moms. As you go through Eat, Sleeps, and Consoles, we can give you a blank diary for your sites, and you can use those for the moms, and they can fill in the things that they're seeing with the babies, how long they've taken to breastfeed, how many minutes on each side, if the babies are consoling, if the babies aren't, how long they slept, did they feed well, they're checking for stooling, things like that. So just sit down and go over those diaries with them. What kind of measures they're needing to actually soothe and console the babies, how long they've been doing skin to skin. So just a lot of open-ended questions. As you go through the tool itself, and that's why I really like the Eat, Sleeps, and Consoles tool, if you look at that, It has all the non-farm care interventions. You can put an I for indicating that you are let me skip ahead. You would want to put an I for the ones you want to increase. And then what I do is, as I'm talking to the mom about the specific ones, you can put an R for if you reinforced it as you went along. So that's what I'm saying. When you really do these assessments, you're really doing teaching almost every time you do your assessment. So it's not just running in, assessing the baby for NAS signs and symptoms. You're really doing hands-on teaching with the parents each time. So when you complete your tool, you can show your mom what you've been doing. On the assessment, it really shows her that non-pharmacologic interventions to reinforce. And then with your tool, you'll want to indicate yeses for eating, sleeping, and consoling if the baby is having difficulty with any of those related to NAS. And then you would want to indicate a 3 if the baby needs extra help consoling. And then under the plan of care part, you would indicate if you recommended a parent caregiver huddle or if you need a full team huddle. Those are like we talked about. So that's just kind of a nice kind of what we're going to look for in the sim labs, but it also kind of gives you how to use that tool, just some tips there. And then, like I said, show the moms the tools. They're interested in what you're seeing, and it's a nice thing for them to see as well. And then at the end, when we're in the sim labs, if you'll tell us you're done with your assessment, then we're all going to come in and do a debriefing. Your team members are going to come in, and then we'll just talk about the simulation itself. So I think, so for those of you that signed up for CEUs, you're going to need this code word to fill out for your CEU form. So if you need to write it down because you'll need it for your evaluations. So let's go ahead and do the video right now.
Okay, let me get that shared real quick.
Thanks.
Okay, it's gonna stop your screen sharing.
Okay.
Just to let you know. And then this is the correct video? Yes? Or is it this one?
The other one.
This one?
It's not a very good technically done one, but that's the better interview.
Okay, and I'll play it here. Let me know if you can hear it.
Hi, Kelly. Hi. Hi, my name's Kate. I'm the nurse that's going to be taking care of you and your baby today. Hi, Kate. How are you doing? I'm good. Yeah? He looks awfully comfortable in there. He's so sweet. He is a good baby. In his little pink outfit. Yeah. So tell me, how are things going today? Good. Good? Yeah. How's he been eating for you today?
So, pretty good. I was a little surprised because somebody had told me he might cluster feed, but I wasn't expecting him to do it. Yep. So I fed him around noontime, and he took almost an ounce.
That's great.
And then he fell asleep for about 45 minutes. Okay. And then he woke up again, and I didn't think he could be hungry. And he was in his bassinet, and my mom had said, don't pick him up when he cries, because you want him to get used to sleeping in his bassinet, and you don't want him to expect to get picked up every time he cries. So he cried for about 15 minutes, and I had tried like rubbing his belly and some of the other tips that the nurses had told me, but then I saw he was kind of swiping at his lips, and then I thought, well, maybe he is hungry, maybe he is doing the cluster feed. So I picked him up and he took another half ounce and
Okay.
then settled right down.
And how long did he sleep for when he settled down that second time?
About an hour and a half.
That's great.
Yeah.
Yeah, so what did you have to do to get him back to sleep after you fed him? Did he just sort of conk out on his own? Did you
Yeah.
swaddle him or
I
hold him?
I changed his diaper and then swaddled him and put him in the bassinet and he fell right
Fell
asleep.
right asleep and stayed asleep for an hour and a half?
He did.
Perfect. That's awesome. And he looks pretty happy and contented right now.
He is.
Yeah. So it's totally okay to pick up your baby. It
Okay.
really is. Yeah, they love it, and especially when he's a little early.
Yeah.
And we know sometimes babies that are withdrawing need that attention, need that snuggles and cuddles from mom, and so sometimes swaddling them, holding them skin to skin, and definitely picking them up can really help soothe them and keep them happier. So that's really okay to do.
So my mom was wrong?
Well, I don't think she was wrong. I think she's telling you what she thought was best.
Okay.
Yeah, but we've learned some things, and one of the things that we've learned from other babies like Sebastian,
Yes.
sometimes picking them up really helps them.
Sorry. I'm not able to see everybody's.
So when he's feeding,
Yeah.
Would you pause it, please?
Yeah, I gotcha. I can't see anybody's. Show me.
And then this is Anne. I was able to hear the video just fine, but we have several people who say that either they can't hear it at all or they can't hear it very well.
Okay. I think I just need to turn it up on my computer. Let me turn it up all the way. I have it all the way up on YouTube. Let me see if there's any way I can up the volume through Zoom.
Thank you. Betsy, do you think we need to restart from the beginning?
We can do that.
And this time, everybody, I will watch, and if you can hear it, please give me a thumbs up. And if you can't, do chat in and I will stop it again.
Okay.
Thank you.
Sorry, I'm just trying to see if I can get the participant window to show up. Okay, there we go. Let me put that over there and let's restart.
Come in.
Hi, Kelly.
Hi.
Hi, my name's Kate. I'm the nurse that's going to be taking care of you and your baby today.
Hi, Kate.
How are you doing?
I'm good.
Yeah?
Yeah.
He looks awfully comfortable in there. He's so sweet.
Yes.
In his little pink outfit.
Yeah.
So tell me, how are things going today?
Good.
Good?
Yeah.
How's he been eating for you today?
So, pretty good. It was, I was a little surprised because somebody had told me he might cluster feed, but I wasn't.
We're getting a message that Shelby can't hear anything.
I fed him
Okay, let me pause this real quick.
And again, I saw several thumbs up and I can hear it perfectly.
Mm-hmm.
And Alicia says, I can hear it if you turn it all the way up, but if anyone in the meeting talks, then it's super loud. Yeah, sorry about that, Alicia.
Okay. Sorry about that. The video is pretty quiet. I'm just trying to, let me see if I can.
Quinlan, one of the suggestions is that we could show people where to find this on YouTube.
Absolutely.
And then they can watch it on their cell phone or something.
Okay, I will just stop sharing and I can drop the link in the chat. There's the YouTube link.
We have several people who can hear it just fine. I think that we should go ahead and play it for the purposes of today's training. And then for those of you who couldn't see it, do copy and paste this link into your browser so that you can watch it as well.
Mm-hmm. Okay, let me get that going again. And would we like to restart it one more time or just let it keep rolling?
Let's let it keep rolling because the people who could hear it were able to hear it.
Okay, cool.
It took almost an ounce.
That's great.
And then he fell asleep for about 45 minutes. And then he woke up again, and I didn't think he could be hungry. And he was in his bassinet, and my mom had said, don't pick him up when he cries, because you want him to get used to sleeping in his bassinet, and you don't want him to expect to get picked up every time he cries. So he cried for about 15 minutes, and I had tried like rubbing his belly and some of the other tips that the nurses had told me, but then I saw he was kind of swiping at his lips, and then I thought, well, maybe he is hungry, maybe he is doing the cluster feed. So I picked him up, and he took another ½ ounce and then settled right down.
And how long did he sleep for when he settled down that second time?
About an hour and a half.
That's great.
Yeah.
Yeah, so what did you have to do to get him back to sleep after you fed him? Did he just sort of conk out on his own? Did you swaddle him or hold him?
I changed his diaper and then swaddled him and put him in the bassinet, and he fell right
asleep and stayed asleep for an hour and a half?
He did.
Perfect. That's awesome. And he looks pretty happy and contented right now.
He is.
Yeah. So it's totally okay to pick up your baby.
Okay.
It really is. Yeah, they love it, and especially when he's a little early.
Yeah.
And we know sometimes babies that are withdrawing need that attention, need that snuggles and cuddles from mom, and so sometimes swaddling them, holding them skin to skin, and definitely picking them up can really help soothe them and keep them happier. So that's really okay to do.
So my mom was wrong?
Well, I don't think she was wrong. I think she's telling you what she thought was best.
Okay.
Yeah, but we've learned some things, and one of the things that we've learned from other babies like Sebastian is that sometimes picking them up really helps them.
Okay.
Yeah, so we want him to be as happy as we can get him, and that's one of the things that can help him.
Okay.
Yeah. So when he's feeding, how does he do feeding? Does it take him a while? Does he kind of suck it right down?
Yeah, within 5 or 10 minutes.
That's
he
great.
Drinks the whole bottle.
Yep. Perfect. So he's been sleeping a lot in his bassinet, and he does okay swaddled and sleeping in the bassinet like that?
And sometimes, we do skin to skin too, because
Yep.
he likes that.
Perfect. And you said he settles down pretty quickly. How long would you say it takes him to calm back down after a diaper change and
Less than 5 minutes.
Oh, perfect.
Yeah.
That's great. I like it. And I know you've been here quite a bit with him.
Yep. He did have to go out to the nursery. They came and took him for some sort of test. So he's gone about a ½ an hour, but I took a nap while he was gone.
That's great. That's a great idea.
That felt really good.
Taking care of yourself is important too, right? Yeah. So do you have anybody here with you for when you do get tired?
My mom comes in.
Great.
Periodically. His dad had to go back to work.
Of course. Yeah, that can be tricky. So do you feel like you're getting enough rest, and you feel, I mean, it's hard with a newborn, of course, but feel like you're getting some support and...
I think so. I'm pretty tired still.
Of course, yeah. Yep, well, you can feel free to, use some of the nursing staff while you're here to kind of help if you need that ½ hour nap. That's okay.
Okay.
We want you to be in a good place to take care of that baby, especially if your mom can't be here. But you're doing a really, really good job with him. Keeping him, happy and fed and spending so much time with him is really, really good. Well done. Can I just take a peek at his diary? Perfect. And he's peeing and pooping. He had a little watery stool, I see.
Yep.
Just the one?
Just the one.
Okay. Great. Well, it looks like he's doing really, really well.
I think so.
Yeah. Let me see here. And I think, things that you're doing really well. You're feeding him when he's showing you that he's hungry, and you're, changing his diaper first thing when he gets fussy, thinking that might be something that he needs to be comfortable. And the swaddling is great. You're doing skin to skin, and all of that is really, really good. It's important to keep the room dim and quiet, and I know you haven't had a ton of visitors, so that's really, really good too. Good for Sebastian. I think you're doing things really well.
Thank you.
He's doing amazing.
There we go. Did you want to show the other video as well?
Betsy, you're muted.
No, I think we'll just go back to my slideshow.
Okay.
I don't. Do I have screen control?
You should. I made you co-host, so you should be able to screen share now that I am.
No.
I'm not.
Cursor there.
Oh, there you go. Sorry, I'm gonna make you guys dizzy for a second. Okay, so that was, I liked that one. I did send you guys the OSCE. So there's 2 other videos that I sent you just kind of in your pre-work that if you want to, you can look at. But I liked that one the best because it really showed just a good assessment. She really was down with the mom. She was engaged. She enforced non-pharmacologic interventions with her. I thought it really showed a good assessment. So what I want to do now is just kind of go over some of the other simulations, and this is your time to do group work with us. So we're gonna, like I said, go over some of them, and then I want your input on what you would do with these. And I'm making you dizzy. Slideshow. I want to bring this up full screen, sorry. So in this scenario, and I copied these and they should be in your packet for you because they're kind of hard to read here. We have a 2-day-old infant. Mom was on prescribed buprenorphine for the past 8 weeks after finally getting into a treatment program. She'd been trying for 6 months to get into a program with little success due to the long wait list. As soon as she heard she was pregnant, she switched from street oxycodone to Subutex because her sister said it was safer. She tried to stop her oxycodone cold turkey, but she went through withdrawal and she had significant cravings. So she was worried she was going to go back to using heroin, so she got herself on Subutex. So at this point in time, she's rooming in with the baby. She's doing lots of skin to skin. She's keeping him calm. She's been exclusively breastfeeding. She has a good latch. She fed him 10 times in the last 24 hours, and weight's only down 2% in 2 days. The baby slept well during the day. However, in the past 4 hours, she only slept 1 hour after a feed, and she's waking up frequently and queuing to feed. The baby falls asleep after each breastfeeding. While awake, she consoles within 3 minutes after swaddling or skin to skin. Mom's worried that the baby may feel badly, as it should be a she, withdraws from her medications or her buprenorphine. And she knows this is very uncomfortable because of her experience. So when you're doing this assessment and talking to this mom and looking at this baby, tell me what you would do. Dr. Jackson's monitoring the.
I'm looking at you, so raise your hand if you want to contribute, and if you don't, I'm just gonna call people, and if you can chat in, if you don't have a camera, go ahead and chat in. I'm gonna call someone in 3, 2, I don't see any hands up, no hands up, okay. Sorry, Amy Henry, you're the first picture I see. You wanna tell us what you would call this?
Well, I mean, to me, it sounds like baby's eating pretty well. 10 times in the past 24 hours with a good latch. Yes, weight's down a little bit. Have been sleeping well except for the past 4 hours. So is this baby really just cluster feeding? Because it does calm and settle. It consoles within 3 minutes with swaddling and skin to skin. I guess are my thoughts.
Yeah, so for the first, taking 10 minutes, more than 10 minutes for eating, or eating, he's eating appropriately for his age, right? So I think you could say that's normal. And that's what Betsy pointed out earlier, that Eat, Sleep, Console gives you the space for a baby to do normal feeding. If he's feeding and calming, that's normal. If he's feeding frequently and frantic in between feeds, that's not normal. This looks like he's sleeping, so you're gonna have a no for that. And consoling, you have a no for that. So yeah, so right now we have no need to call a huddle. As the nurse, you would reinforce what she's doing and maybe make suggestions if there's room, but I'm not sure there is right now. Just kind of, I think supporting her, the mom's discomfort and helping her with her own anxiety can be helpful.
So, and also with her being worried about the baby and how he feels and her anxiety about him going through withdrawal, I think you can really reassure her and point out, you know, looking at the signs and symptoms of withdrawal, pointing out that right now he's not exhibiting those signs, and just kind of reassure her that this is normal cluster feeding at this point, to just really reassure her that he's not feeling the symptoms that has gone through in the past, and that you're going to help her support him through those if he does start to develop those, just to kind of calm her down about those. I mean, it's really amazing when I do prenatal consults, the guilt these moms come in with. So just supporting her through that is huge. So, okay. Questions about that scenario? So, okay. Guys, don't always speak up. It's hard for us to know what you're thinking virtually. So.
I have a question. This is Jessica at Hayes Med. So when you're doing the assessment with them and kind of like going through it, scoring, do you just kind of make notes on the form and have that, or do you have something in the medical record that represents this there?
So it depends on your system. If you can get your system to put this in your medical record, that's where you would do your permanent charting. I think this is a great form to take into the room with you, because this, I would show the moms with it. So like when at Shawnee Mission, when we do the Finnegan scoring, we chart it in the computer, but I have a bedside tool, that's the Finnegan, that the nurses take into the bedside with them. They score with the parents. They show the parents exactly what the babies are scoring so that we can modify those comfort measures based on what the babies are scoring. So I think this tool is a great tool to show the parents. You can literally, the one video I didn't show you is the nurse saying, this is a new tool for me. I'm going to show you exactly what the tool is and you can see it. Or another nurse says, here's what I'm using. And then they basically went over every non-pharmacologic intervention together. And you can just say, you're doing a great job on modifying the room. You're keeping it nice and quiet. If they have 10 visitors in the room, which right now none of us have 10 visitors in the room, but when we get back to our norm, there's lots of people that have tons of visitors, and you can go in the room and kind of say, this is why, you know, we limit visitors. And so I think it's great to have the tool in the room.
Okay. And then do you have kind of something tangible for the parents to have for their education about these things as well, so they have something to refer back to on their own if they choose to?
So we have like parent handbooks about NAS and comfort measures and stuff like that. Dartmouth has a parenting handout that they have given us with their tool on it as well. So there's a lot of, KPQC has a handout that we have on our website we've modified it for all levels of the NICU, the newborn nursery, that has everything about NAS and comfort measures and how to care for your baby that you guys can go out and get. And then we will also put Dartmouth's tool and parenting handout as well on the website under references.
Okay, thank you.
Your part about charting, if this system isn't built into your computer charting, you do need to chart something in the computer. So you'd have to agree in your center, what are you gonna chart? How are you gonna chart it? You should probably make a script or a text box or something that everybody can chart the same. So you could say, you could list the EC consult components and give a yes, no, and then have a place where you talk about which non-farm care interventions you discussed. But it's important to have this charted also.
Okay, thank you.
Any other questions before we go on to the next one?
And Anne just put in the chat the link to the KPQC website that has the NAS resources in there, so you can get to those booklets that we put up there. And Heather asked, could those links be sent to our emails? And
okay, thanks.
I'm sure Anne can do that because she's really good at that stuff. Okay, I'm gonna call someone next, so get ready to put your hand up.
Okay, so our second simulation, we have a 2.5-day-old infant. Mom was on prescribed methadone for the last year for a history of opiate addiction. She continues in an outpatient program. She's doing well in it. After rooming in with her baby, she's doing lots of skin to skin. She's limiting her visitors just to support people, and the environment's calm. She's exclusively breastfeeding. The baby was feeding every 2 to 3 hours with a good latch. However, in the past 4 hours, baby's feeding every hour. It has difficulty latching, feeds for only 5 minutes. He's noted to have an excessive suck and root, and his weight is down 9%. And he's 2.5 days old. The baby's now sleeping only an hour at a time. He startles easily. He has increased muscle tone and tremors. The baby was consoling easily with swaddling and skin to skin and feedings. However, he's now more difficult to console. He cries for more than 10 minutes despite non-pharmacologic interventions to the mother's best ability. So at this point in time, you've gone in the room, you've done your assessment, you're talking to the mom. What do you think about the baby, and what will you want to do? And how are you scoring him?
Okay, I'm looking. Who wants to talk?
I'm looking at you all. You guys who don't have screens are a benefit. Alicia, you're looking up. Does that mean you have an answer?
I had to turn you up. You were really soft.
Can you hear me okay?
No, I can't. I turned you up.
Do you want to talk about how you'd score this one?
Sure. Well, it sounds like initially baby was doing well, was doing the eating, sleeping, controlling, so would have gotten no scores for any of those. But is sleeping an hour, so would pass on that, although it doesn't sound like it's going well. Is not consoling, crying more than 10 minutes. Feeding is not adequate. So I would say this baby would not pass eat, sleep, console. It looks like mom has been doing the breastfeeding on demand. She has been keeping the lights down low. She's been doing the skin to skin. She's been doing a lot of the things that we would do for non-pharmacologic care. I'm not sure how much more could be increased in these regards. I'm assuming if she was breastfeeding well before, that it's not going to be something where it's a latch issue or where she could change things there. Baby's already feeding or attempting to feed every hour, so catching at early feeding cues would be hard more frequently than hourly. I would be tempted to go ahead and start this baby on medicine at this point.
So, do you want me to chime in or do you want to chime in about supplement?
You and I are both on the same page, so go ahead.
Okay, I guess it's me. Things aren't going well, you're right, and they certainly have gone downhill. But one thing that's possible is that we have a mismatch between mom's supply and what the baby needs. And also, perhaps the breastfeeding wasn't going as well as we thought it was. So just like any other baby who looked like he was feeding well, but suddenly has an excessive weight loss, we really want to assess how that breastfeeding is going and are we getting enough food in. I often ask the moms who are in the situation to pump early to get some extra milk going and get the milk in faster, so that if we need a supplement, we can use breast milk, and the breast milk has the medication in it, so we're kind of treating a little bit by the small percent of methadone that would still be in the breast milk. Also, it helps increase the supply faster so that when baby does latch effectively, he's going to get a bigger volume, which may be able to satisfy his excessive hunger needs related to withdrawal. So definitely withdrawal is a component here, but we may be able to soothe it with a little bit more food. And so my next step would be to think about ways to get more food into the baby. I would, at this point, if I already didn't have mom pumping, I would have her start pumping. If he's latching well, we could talk about tube assist at the breast with formula or with express close milk if she's getting anything. If the baby's not latching well, you can think of alternative feeding methods. It's a little tricky, and this is a situation where you have to really kind of sit down with your lactation people ahead of time and talk about how these babies are different than other babies, and that actually sucking and swallowing is an important part of how to treat their symptoms. And so I'm not a real big fan of cups and spoons in this kind of baby because the sucking and swallowing, like I said, helps relieve the symptoms. It's actually a treatment. It's a non-pharm treatment. So if we can get the baby at the breast with tube assist, that's great. If we can't, then kind of a upright paced bottle feed is what we do. So we don't let them get food too fast, and it's a little bit more like a breast, but we're just at least getting food in. So in my opinion, there are some more non-pharm things we could do here before we needed to medically treat. And if the baby actually had a little more food, maybe he'd be less fussy and he could sleep a little longer, and it would help with his weight loss. And if mom started pumping, perhaps we could get her supply up to where she can give the baby what he needs. So that's my contribution there. Do you have anything else, Betsy? Does anybody have any questions or comments about that? This is a conversation you have to make sure your nurses and lactation people understand, because for those people who are baby friendly, this goes against a lot of what people are being taught. But when you have the choice of giving some extra food or going on morphine, I vote for the extra food pretty much every time.
So
This is the same baby. It's just a continuation. So it's our 2.5-day-old baby. It's the same history. Mom still has the same history. So on the infant's last assessment, he was noted to have poor feeding, consoling, and sleeping, and they were related to NAS symptoms because we talked about the tremors and stuff. You guys did a team huddle with the mom and the RN, and the non-pharmacologic measures were reinforced. Lactation came down. They reconsulted. They did non-nutritive sucking. Grandma came in. She held while mom took a nap. So we did some comfort measures for mom. We gave her a break. Mom continues rooming in and doing skin to skin. The baby breastfed with tube assist with lactation. So we did get some more food for the baby. The infant breastfed for 12 minutes with improved latch and supplemented with 25 mils per tube assist. And but now he continues to have excessive suck. His weight, like we said, was down 9%. Now the baby slept for an hour after the feeding. He woke again crying. He's noted to have tremors, excessive muscle tone, and startles easily. The baby's still difficult to console. He cries for more than 10 minutes. We've attempted to refeed him. We've swaddled him. We've done skin to skin, a calm environment. We've reinforced our non-pharmacologic interventions. So we've addressed the feeding issue, but he still is unconsolable. So now what will you do?
Okay, somebody volunteer. I'm gonna just pick somebody. I only have like 5 to pick from, so.
Did we lose everybody?
We've heard from Wesley and we've heard from Via Christi. So shall we maybe get Kayla from Gary?
Oh wait, no, Heather chatted in. Thank you, Heather. Heather, she doesn't have a microphone, but she chatted in and she said full team huddle. Good job, thank you. And then she said, and then Emily says, I agree. So full team huddle, we've done everything we can do. There's really not much more to do. Full team huddle. We call in the provider. Maybe the provider has some secret answer. I don't think I would. I would feel like my role in that place would be to help mom get to the point where she understands it's time to treat, which is a very important aspect of the Eat, Sleep, Console package, because this huddle not only helps decide it's time to treat, but helps get mom's buy-in on that. So I would go through as a provider all the things that are on that list, and I say we've done all these things. The feeding seemed to help a little bit, and I'm glad, but that's not enough. So we know it's not just he's not getting enough food in his body. He's having all these signs of withdrawal besides the not eating and sleeping and consoling. He's having these other physiologic signs that tell us his body is really struggling without seeing that medication anymore. And I think it's time to give a medication to help him do that and ask mom to chime in and get her agreement. And usually when the families have been struggling for this long, because now it's been a few hours, they're ready for that. But our practice previously had been to just kind of go in and say, okay, we're taking your baby up to NICU to treat it. And that never really went over that well. So having that huddle and that discussion and making sure mom understands before we do that, I think does a lot to improve their engagement and their trust and realize the baby's not just going to go away and get treated, that she's still invited and actually required to participate. Any comments on any of that? Oh, we've got some, let's see. Oh, we've got a lot of full team huddles. Thank you, all you people I can't see. And then I got B. Chapel say we would probably have to transfer the baby to a larger facility. So yeah, if you need to do that for treatment, you could. And also if you have a smaller facility, you can start thinking about doing a one-time dose and seeing how that holds you while you start thinking about trying to transfer if you need to. I really encourage the smaller facilities that don't feel like they can do long-term treatment to start thinking about a low dose one-time morphine dose. The low doses that we use aren't really going to be associated with the things you worry about like apnea. And it's a project to think about at the smaller centers. And thank you, Michelle, for enjoying our conversation. And Chapel wants us to share the low dose information. Yes, we can
do that.
I think actually we've been talking about what webinars to do. I think we should do a webinar on the PRN and how it would look.
Okay.
And we can't like officially endorse it as a best practice, but we can tell you about what people are seeing and what they're doing. And I have a couple of presentations from a meeting I was at that have some at least local QI stuff. And Michelle says, I feel this will really help reduce the guilt of mom and know that she is still able to participate. Yes, absolutely. That's our goal. It's still part of the treatment. And that's the thing we say from the very beginning. You are the most important part of the treatment. Even if we need medicines, you're the most important part of the treatment here. You and your people who support you. Okay, anybody else on our chat box? Thank you, everybody who's chatted in.
So I want to try to get through one more scenario before we move on. And this one I think is important because you really have to assess everything going on. So in this one, we have a 40-week-old healthy boy born by C-section after a difficult labor and delivery, or difficult labor and failure to progress. Mom is 31 years old. She was on Prozac for depression. She's on Subutex for treatment for 3 years. She's doing well in recovery, and she had no other medication or substance exposure except for Prozac and her Subutex. Babies had problems staying latched, does not seem interested in feeding much, and has been spitty. Mom's doing lots of skin to skin. On day 1, babies had increased muscle tone, difficulty sleeping for more than an hour due to tremors when disturbed. Since the last assessment, he's been taking 10 to 15 minutes to calm with swaddling and holding. He's been passed around between grandparents. Because they're all excited. They've been talking aloud. They're having, because of hearing problems, and the family members want to hold him. Let me think. So that's day 1. On day 2, so on day 1, really, baby's actually doing fairly well. He's had some increased tone and difficulty sleeping, but you also have a very loud room. I'm just going to walk through this because I don't want to have to ask questions each time. Basically, you would need to modify that environment. You probably need to kick your grandparents out or have them talk more quietly. Just reinforce that you can't be passing the baby around to every family member. Day 2, the mom's been keeping the environment more to herself. It's nice and quiet. The grandparents have gone away. The baby's no longer spitting up. Since the last assessment, the baby slept for 3 hours. The mom's been able to take a nap. When baby awakes, he's very fussy, but he's able to calm after feedings, and he's and skin to skin. He was able to latch for a few minutes and then breastfed well for 15 to 20 minutes. On day 3, he's having a harder time consoling today. He's continuously rooming in, no visitors, and being held lots. Parents are calm but a little distressed about how baby's feeling. Baby's been taking 20 minutes to settle down with maximum support, has problems staying latched due to excessive rooting, tremors. Mom's doing lots of skin to skin. She's trying to feed every 2 hours to avoid him getting too hungry, and baby's fussy. So what would you want to do with this scenario? Sorry, it's a lot of days in a row.
Okay, I welcome you all to either raise your hand or chat in. And Matt pointed out to me we haven't heard from Gary yet. If somebody from there wants to say something, or somebody who's already talked wants to say something.
So are you wanting to know for day 1 or day 3 or all of it?
All of it. Well, all of it if you want.
Just give us your tell us about the baby, what you think from day to day.
So day 1, you talked about modifying the environment, not having the baby passed around and asking people to leave, because the baby is not doing well, but it's probably more so because of the environment and the people around. Where and you can see that on day 2 because the baby did better when those external forces were gone. When you go to day 3, it's different, and I think there needs to be a huddle because the baby is no longer consolable, is not eating well. Maybe feed more often or evaluate the latch, have some lactation support.
Great. So that, and then Dave, just remember that with mom being on Prozac, sometimes in that first 24 hours of life, it can cause, some interference in some of those symptoms, even the first 24, 48 hours of life, that sometimes you'll see some of the symptoms of that medication. Those symptoms should get better with time because those come out of the system, whereas opiates, the withdrawal symptoms get worse with time as babies start to go through withdrawal. So, okay, very good. Let me see what time it is. All right. So I think what we'll do is, I did go ahead and there's another case that I'm going to leave in there on the PowerPoint, and then you guys can just review that, and then the case reviews that we'll bring to Sim Labs are also there. The case reviews you can read through, be familiar with. With the OSCEs, there's actually videotapes of those two that I sent out with your pre-work. So as far as hospital implementation, what we kind of just wanted to go over is just some tips to make it easier, or tips to consider as you start to put in Eat, Sleeps, and Consoles into place, or even just pieces of it in place. The last time when we did our training, we actually got to do live trainings in March. We had 5-6 centers come, and we have a couple centers that want to try to implement the whole thing, but we had a bigger center that just wants to take pieces of it and place it along with their modified Finnegan, and just so that they have all the non-pharmacologic cares along with the modified Finnegan, and just kind of incorporate it into one big tool. So there's not a right or wrong answer. We're here to support however you guys want to do this. We're here for questions. We're here to help you implement whatever you want to do. But here's some tips as you move forward. I mean, it's a project, definitely, for sure. It's time consuming. So the biggest thing is to get buy-in from your providers, because if you do Eat, Sleeps, and Consoles, you will have to have provider involvement, especially when you get to that second team huddle or the full team huddle. You'll have to have a way, especially if you're a smaller center, at midnight, if you need to get a hold of them to make sure that they can be involved. And they have to know about Eat, Sleeps, and Consoles. They have to know about the tool. They have to be familiar with its use. You can't put something into place and have a pediatrician or a family practice physician not know the components of it. So they have to be comfortable with what you're going to do. So a lot of times you can share the data, why you want to do it, why you think it's better. Share that we can share the articles, the QI articles with you so that you can let them have an informed decision. We are recording today's session, so if you want to share today's session so that they can learn about it that way, we're more than happy to share that as well. Leadership or corporate, absolutely.
Sorry, I'm reading the chats as they come and Betsy's talking, so I'm going to interrupt her to address them. So we've had a couple chats about, a lot of patients don't know about how antidepressants can affect babies and methadone and smoking. And then I have another chat that says, we really wish our OBs would chime in. And then another says, can you speak to how much education patients get prior to delivery? Who does it? So those are really, really good questions. And that's really the important starting point and a big difficulty to overcome. But you can have the best in-hospital system. And if you don't have parents ready and understanding what's going to happen, then it can just really backfire because the parents really need to partner with us on this. So that's a great place to start. And sometimes it's hard to get the OBs to join in. We've struggled with that over the years because they don't know a lot about the subject. They don't feel really educated enough to support it. And also it takes a really long time and they don't have that built into their system. And also they don't want to upset their patients. So what we did at our center and what we've supported other people to do, we've done actually through our whole metro and we've supported other centers, is to really reach out to the OBs with information and create written material that they can easily hand out. So nice looking material, and you can just take ours. So Anne put the website up, go in and take ours. We changed it so you could use it at any center. But the parents really like to see a nice piece of written material because it makes them realize it's not just them, that this is something so important that we've actually created a booklet about it. And it's not just us telling them this one thing, but that it's frequent enough and serious enough that there's a whole bit of material to introduce it. And we don't only give the booklet, we give other pieces of information to our OBs. And some of them just put them in their mom's packet, so they're there, but they don't address them. But we really, really ask them to address them. And most OBs aren't comfortable addressing them, so we set up.
High wind warning in effect for Johnson County until 12:15
we have high winds again.
Wind gusts are expected up to 70 miles per hour. Attention please, high wind warning in effect for Johnson County until 12:15 hours. Wind gusts are expected up to 70 miles per hour.
So the other thing that we've done at our center is that we have the people who are considered the champions. It's been Betsy and me mostly at our center. We have a system that OBs can refer their patients so that we meet with them before delivery. And what we find that is worth every second of our time. We don't charge for it, but it's so worth it because if we meet with them before they actually come in to deliver and talk about the long-acting narcotics, that they'll have to be observed for 5 days, the short-acting for 3 days, what we're looking for, how they can partner with us, give them the booklet so they're prepared. The experience when they come in is night and day of what it is if they're not coming in with that. If they're coming in expecting to have a normal delivery and everything's gonna be fine, they're gonna go home, and somebody comes in and says, actually, we need to watch your baby for, more days, or your baby could have trouble. It ruins the birth experience. It sets them into a defensive position that we have a lot of trouble partnering with them in that situation because they're just so angry. So anything you can do to get information in the hands of your patients before they come in. In the smaller places, I mean, one of the things we did is we basically stopped the OBs. We made an appointment with the OB, what are they called? The office managers. We make an appointment with the office managers and we would go in the morning as they were getting there and we'd had all our paperwork to hand out and we'd tell the OBs a little bit about what we were doing. And of all the things that we've done from a neonatal perspective that involve OBs, this has been the best received because they know it's a problem and they're really kind of struggling with what to do about it. So if we say, look, we've got it, we've got this literature, we can talk to your patients. We've given our cards to the office managers to set up appointments. So all the OB has to do is say, hey, I want this person to have a prenatal appointment. Then the office manager can call. We have a person who's doing the scheduling for us now. We didn't start that way. It was just, they call us directly. And we'd get them in. And like I said, it's worth every ounce of effort, tenfold, to get them educated before they come in. We also would give them a copy of the Finnegan scale, so we knew what they were looking at. If you transition to Eat Sleep Console, you could actually hand them the Eat Sleep Console tool so they can know what you're looking at. We use symptom diaries. We've presented that in previous presentations, where they keep symptoms when we're not in the room. That we can give them a copy of that. Is that available on the website, the symptom diary?
I think so.
Yeah,
Under
so
us.
we think it's under. So if you go to the resources, there are resources, there are KPQC resources, and then there are peer resources. And under peer resources are all of your centers and what they do. So you can look under Event Health and see what we do. You can look under your other peers. I think that Wesley has some good material, and Overland Park has some good material, and other Stormont Vale. So, and maybe some of you guys do. And as you develop your material, you can share it there too, and improve on everybody else's.
The newborn diary is part of your packet, and it will be part of the Eat Sleeps Consult packet that you guys will get. So
somebody, Alicia says, we go to the treatment center to educate prenatally. We do not capture those on long-term opioids who are not in treatment. So yeah, if they're in a treatment center, you can go to the director of the treatment center and tell them to call you. But the other thing is that the ones that aren't in treatment centers, you just got to get those OBs to get them into you. And the other thing we struggle with, even though we've done that over the years and we've been doing this since 2012, sometimes a lady will come in who's been prescribed something from their OB and we don't know. And so I have a form letter I send out every time that happens. It says, thank you so much for working with us, and we love meeting your families beforehand because we help know what to expect. And so I send that out 2 or 3 times a year when they forget. So it's not easy. It's way easier to teach Eat Sleep Console than it is to get OBs to refer your patients in, but it's such an important part of the process. Putting more time on that. I mean, you've got to get those families in before you can really plug them into a good system. Questions about that? There was 3 or 4 good questions. I think I addressed. Oh, wait, let me go back. The question was, they don't even know about the antidepressants and smoking. So yeah, that's a big problem, because then they have all this guilt. They're like, oh, I didn't even know my antidepressant could be a problem. I would have come off of it. And do we have our other booklet, both booklets, the NAS and the
I think our main stabilizer
is it under us or under
it's
KPC?
under us.
Okay, so if you look under our center, we have a separate booklet for mood stabilizers. And because it's different than narcotics, the very first page says, don't go off your mood stabilizer, basically. There's a quote that says, it's more important for the mom. It's most important for the mom to be healthy mentally and physically, and for the baby in the long run. So it's really important they don't arbitrarily take themselves off meds that people have prescribed to them. And that we try to make that case. But at the same time, babies can have trouble. Not all the time. A lot of babies don't have trouble with mood stabilizers, but sometimes they do. Sometimes, most of you who maybe go to deliveries know, sometimes they don't breathe right away. And that's kind of the most striking, but sometimes they don't eat as well, and sometimes they're excessively fussy or excessively sleepy. That isn't so much a withdrawal. I guess it's kind of a withdrawal. At first it's a drug response, later maybe a withdrawal, and it goes away, and it usually doesn't require treatment. But on top of narcotics and smoking and everything else, whenever you add any meds on, you're going to have more trouble managing the baby. There's no question about that. And the smoking is a huge deal. And if we could get more OBs to think about doing patches and things while women are pregnant, that would be really helpful, because at least that'd be a steady state of exposure. One of the problems you have with any medicine is when you have big peaks and valleys of exposure, you have worse withdrawal. So that's why women who come off and then binge, why that's so bad for the babies. It's also bad for their brains, but it's bad for their withdrawal. And for people who are on short acting. It's why it's important to get them on a long acting program, because the short acting, they have a peak and a drop and a peak and a drop, and you get a lot of problems with those neuroreceptors that we talked about, where if you have a steady state of exposure and then it drops off, you can kind of get through that easier and your babies respond better. So definitely awareness around smoking. That's a huge one. It's so hard sometimes to tell the effects of smoking withdrawal from narcotic withdrawal when you have both. And I'm not sure it matters entirely if you're not eat, sleeping, and consoling, but it's a big issue. So let me see if anybody else. So Anne put the link in again and said, just scroll to the bottom after you go into the resources and you'll see the peer. Oh, our antidepressant is in there. The second antidepressant is there. So she says send that to everybody if you want to look for that. And if after this you guys have trouble finding things, we can make sure that you get them too. Does that address all those questions around parent education? Okay, I don't have any more chats, so I think we can go on.
And like that, in our parent education, I mean, not only do I meet with moms with opiate exposure, our OBs will actually send us mood stabilizers if they're, especially if they're on 2 or more exposures. I will meet with several of those moms as well. So I think that's where our strength of our program is. So I never turn those moms away just because they're just mood stabilizers. I'll always meet with those moms. So when you look at the impact on several departments, and this I think is probably worth looking at, it's just what do you do with Eat, Sleeps, and Consoles, and how do you lead out on it when you have low census in your unit. And I think this is just when you're doing the Finnegan, it's difficult to do it also when you have low census. So again, when you're teaching, just to keep current, your videos, do competencies. I do a lot of video checkoffs with our nurses. I'll make case studies for them. Just attending. What we plan on doing is really kind of shifting some of our learning forms now towards Eat, Sleeps, and Consoles. We'll address some of the PRN, morphine, things like that now. Pediatricians not in-house, again, a good HIPAA, a compliant phone, things like that. Ways of being creative to get them at 2 o'clock in the morning when you need to. Not enough volunteers. A cuddler program is awesome if you can develop that ability. And if you have questions about that, we can send you information on how we developed ours. I know Overland Park has one. We can get them to weigh in on that as well. Stormontville as well. So we have a lot of centers, bigger centers out there that have cuddler programs that we can help get sources of information on developing those. Ours started small. We started out with a team where they were in-house just in the morning. We've expanded to the afternoon, and then we evening, and then we got weekend coverage as well. So it just takes us time to grow it. Ours are generally the older population, but student nurses need volunteer hours, anything like that. If your hospital's not set up for rooming in, it's definitely a more difficult program, but being creative. If you have pediatric units, using labor and delivery beds, it's hard when you need to have lockdown units. Just kind of thinking outside of the box. Restrictive policies that you have that only moms and dads can visit. They have to be with moms or dads. We bent the rules for our NAS babies where You know, the grandmas can come in without the moms just to provide comfort cares as long as we have driver's license, things like that. So kind of easing up on the restrictions for visiting for these babies. I don't, as far as overstimulation, we covered that. And so I'm just kind of, I don't want to beat you guys to death with these either.
To expand on what Bessie just said about having a broader invitation to people to help hold, we actually extend it beyond grandparents. We say to people, anybody really in their community that they think that could help. And then we have a list. They have to give us a list and they have to tell us who's coming. They need to be okay with that person hearing information though, because although, you know, we try not to purposely give them information. If you have a person there at the bedside, they hear stuff. So we talk through who they might want to choose, but we try to have them choose a pretty extensive list, especially on babies who are going to be here for a while and being treated, you know, up to 21 days, sometimes more. That gets to be a lot to expect the mom and dad to be there the whole time. So that took some work because we did have a pretty strict policy about visitors, mostly because of HIPAA, and that can be worked around.
Yeah. So, and then that, like I said, this space, looking for alternative ways to find rooming in places. Parent education, I think Dr. Jackson hit a lot on that as far as really preparing these moms beforehand. We found that if we don't get the mom in beforehand, we do try to get to her before she delivers. Trying to educate a mom right after she delivers is so difficult. I mean, we do it if we have to, but even trying to educate her while she's in labor is difficult. They're not focused. It's just difficult. If I have to choose, I'll try to educate her before while she's in labor, then right after. Right after, they're focused on the moment. They've just had a baby. It's just extremely hard. Our best bet is if you can start to educate moms prenatally. It's difficult to start a program, we'll be honest with you. But going out and soliciting help from your OBs, we really want to see these moms. It's made a big difference in our response from our parents. They're prepared, they know what to expect. They're involved, they're ready to take care of their babies, and just seeing the education material we have for them takes away some of that guilt. And then working with your parents, if they're not unable to stay for extended periods of time, helping them have other routes, other people that can come in. I think. And then the other one, the disagreement among team members, again, your full team huddle, really talking about the baby through, making the parents coming to a decision along with you, especially when you need to medicate a baby. Considering PRN dosing if you're at that point. And that's when your physicians, you as a nursing staff, and your parents all need to be on the same page. So. And then the last thing is just a tool for hospital, your team. It's just kind of helps you set goals. Forming multidisciplinary teams to kind of take these projects into fruition is excellent. Just kind of who all you want to be on your team. You have to have a team leader if you're going to lead out on Eat, Sleeps, and Consoles. To really, I mean, if you guys just say we want to do it, but nobody kind of takes the head on it, it kind of fizzles out. In order to train, we're going to train you in the sim labs, and then you guys will go back and train your facility. We'll be glad to support you as you guys do that. We're not just going to train you and throw you out there. We'll be happy to help you with questions. and stuff like that. And then we're going to turn some of the learning forms into more support as we go along. So I think that's the big thing. So what I want to do is take, and I'm running a little bit early, but I want to give you some extra time to do it too. I want you guys to go into breakout rooms, and with your breakout rooms, I gave you it was your SWOT analysis. So your strengths, your weak and obstacles. You would think I'd know it right off the top of my head. I did give them that handout. So pull out your SWOT, your strengths, your weaknesses, your opportunities, and your threats.
You see that?
I don't think they can.
Yeah, I can, and not.
Oh, can you? Okay. I don't know what you can see on my screen. I'm so sorry. I want you to take that into your breakout room. And then I want you to take out, you should have your ESC goals. And then we're going to take that into your breakout room. For your breakout room, you're going to go with your center into your breakout room. And Becky, I put you in with Geary County so that we have 5 breakout sessions.
Sorry,
I can't see
just
it.
asked again, what is the SWOT, the acronym for?
Strengths, weaknesses, opportunities, and threats. So what would be a threat to if you wanted to implement Eat, Sleeps, and Consoles? Like if you're a smaller center, you don't have adequate rooming in, or even if you're of a bigger center, your pediatricians don't want to participate. And so you wouldn't have anybody that would participate in team huddles. Your upper leadership doesn't want to invest the time and resources into training staff, anything like that. Strengths, you have a lot of support from your obstetricians. They really want you to educate your parents. It's just small goals right now. It's not, I'm going to take this back and I'm going to implement Eat, Sleeps, and Consoles tomorrow. That's not what I'm looking for. I'm going to look at starting some parent education materials. I'm going to ask the OBs if we can talk to the parents prenatally. Small goals. And that's why you have more than one goal. Just things like that. Make them specific, make them measurable, and time specific. So, and whenever you look at goals, you always want to look at your baseline and and so they would be measurable. So, so you know that you would make progress. So for us, when we first took our babies and we wanted to make the nurses comfortable, we, in scoring, because we wanted to drop all the babies down on the mom baby floor, we had to educate all our mom babies before we would ever take them down to the mom baby floor. So our goal was that we'd educate 100% of our mom baby nurses, make sure that they felt comfortable on a lacquered score before we ever would take them down. And then after that. So you have to have baseline data and data afterwards. Does that make sense? What's my room?
Sorry?
Doesn't my room?
Well, you've got no chance. We had a discussion about, I'm glad that we asked a question about SWOT because we obviously hadn't explained it well enough. So
oh, I'm sorry.
No, I'm just, somebody said sorry they re-asked it, but please ask questions because if you have a question, other people have questions.
Yeah, definitely.
We want your feedback. This is really hard for us because we can't see you all. We don't know what you're thinking. So any question at least gives us information that we're being heard. And feel free to send any question. And before we break to get in the rooms, I'm not exactly sure how this is going to look, so I'm a little frightened. But before we do that, Ann's laughing at me. Ann's got it all handled, I think. She knows what's going to happen. But no, she doesn't. Okay. I sent something out as we started this section. You probably didn't have a chance to look at it because you were listening to Betsy, which was the right thing to do. But I did want to check in with everybody before we go away from each other and say, what burning questions are there? What makes sense? What doesn't make sense? If everybody could just take a second and chat in something that they learned or something they want to know more about, just to give us some feedback on how we're doing. Because like I said, this is really hard for us. We've done this before. We know what we're trying to say. We don't know how it's going for you guys. I mean, we're on time, so that's good. But that's all we know. So if you could all just take a second and just say something that you appreciate learning or something you want to know more. Is this working out well? Is this really difficult? Is this worth doing again? Because we're planning to do this again with another group. Is this an okay way to learn it, or is this just not working out for you? Tell us what you think, and then we'll break out if that's okay. So anybody, I've got Heather gave me a comment. She said they're working on their SWOT page, but about the presentation, tell us something. Okay, so let me start reading these if I can before they all go away. We see opportunity to educate during prenatal classes. Great idea. I never even thought of that. That's a super idea. The other thing we did do though is we have a navigator who is somebody who meets with all our moms to kind of tour them. And we educated them about it. And we also give them the booklets to give out. And then when they identify people, they call us and make a referral, which you wouldn't believe how often we get moms who tell the navigator they've been taking narcotics the whole pregnancy, but they never told their OB. So if you have a navigator program or what I don't know what else you call it, where people come in ahead of time to sign up and meet with somebody and get a tour of the facility, if you can arm that person with some education and literature to give to the families, that's a really good way to identify people. So we have a comment. This is overall very helpful. As a small facility, we'd love to hear more about PRN dosing. Yes, we want to tell you more. Thank you for asking. Using the tool with others helped us here. Trying to complete it ahead of time was difficult. Okay, that's interesting. We do send it out ahead of time, and it is kind of difficult. But now that you've done it, maybe going back might be helpful. Let's see.
Timing of assessment.
Sorry?
Timing of assessment.
Timing of assessment.
When is the first assessment to be done? She works on labor and delivery.
Where are you?
12/21.
Okay. Well, I'm going to go in order. No, we can get to that one.
Okay.
It was helpful to hear how to organize our efforts. Thank you. We will. When will the first assessment be done? I work like really right now. We do baseline assessment before transfer 2 to 3 hours. Generally, we say 4 hours, but getting a baseline before you transfer is fine. It's another group. Well, depending who your nurses are. I mean, for us, that's difficult because our labor and delivery nurses are different than our mother baby nurses. So we would have to train a whole other group of nurses who weren't particularly interested in being trained. But if you have nurses that cross over, that's a fine way to do it. But really, when you look at the pathophysiology withdrawal, probably 4 hours is the first time you really need to. But doing before that isn't going to hurt, and it'll get everybody kind of in the mood. Prior education with parents would be great. Hopefully our navigator can help us. Yes, and usually, because that's a one-on-one visit, that's a great opportunity to tap into. And like I said, we get a lot, maybe even more from our navigators right now than the OBs. And then they know how to get a hold of us, and they're real good at setting it up. Sometimes when we know ahead of time, we can actually meet with the family when they have their navigator appointment, and that's nice for the family because they don't have to come in twice. This was very helpful. It was great to review and get explanations for each sleep consult form. Thank you. And love all the info. Challenge moving forward is after educating nurses waiting for next patient. Yeah, that's a problem. It's been 6 months since we've had NAS. I need to find out. So yeah, that's really hard, but you can do simulations. With any kind of high acuity, low incident problem, simulations are the way to go. So if you get everybody educated and you don't have anybody for a few weeks, you can do a simulation, at least with the people that are there, and get people practicing. And that's what you do for codes and for other things that don't happen that often at higher centers. But it's important to keep practicing it because you get all educated, and then it's a year. It's almost like clockwork that you don't have a patient for at least a couple months after you're ready, after you feel ready. I need to find out more on the prenatal side and how it works for our moms as far as getting meds. Okay, this has been good format, good explanation. Thank you. Another challenge we have is the family. Recently, the husband does not know. Yeah, that's a really difficult situation. So
I've been in.
Betsy said she's been in that one, and I've been in that one. And then also sometimes it's a grandmother or somebody. So the conversation I usually have with the mom is they're gonna find out, and I can help you explain it if you want, but you're not gonna be able to navigate this if your support person doesn't know. We're not gonna be able to navigate this. And we can have a discussion about, medications that you're given. We don't have to be specific if we don't want to, but we need to talk about the fact that your baby has had some medications that you were taking when you were pregnant that they don't have now, and that we're watching for that. I think when the mom tries to keep it a secret, there's all this guilt and stress on top of whatever else is happening, and it never, ever, ever works. So I think you ended up, didn't you end up, or was Bayou, one of our attendings?
We actually ended up going down and going into the mom's room and helping the mom tell the dad and just really supporting her through that conversation. And then we had been down before. We worked out a plan for her to re-enter treatment programs. So prior to telling him, she kind of had her plan all worked out. And it took a couple days, but they were on a good page when they left the hospital. So just supporting them through that, offering to be there in that situation. It's an uncomfortable situation for everyone, but I think sometimes they need that help.
Yeah, it's so potentially toxic to not have the support people know. It's almost not worth having them there. So if they want somebody there to support them, they've got to find a way to let them know. And if it's been a really kind of dicey story, you don't have to reveal the whole thing. They don't have to say they were illegally using something or anything. They could just say, I was given some medicines for my stress or for my pain or whatever that now are affecting the baby. And it doesn't have to be something filled with guilt and secrecy. And the more we can get the women out of that guilt and secrecy, the more we can help them with their problem if they have an addiction problem, which they probably do in this scenario. If we let them continue the guilt and secrecy, we're really not doing anyone a service, and we're probably not going to be able to give the appropriate care to the baby, and somebody's going to find out if they're there, if that's the reason they're there. So those are really important discussions to be had. I have another question that says, this is excellent. Just to recap, are we supposed to be doing this? The answer is no, you're not supposed to be doing anything. This isn't a potentially best practice. We gave you the potentially best practices in the beginning. And we asked you to try to implement as many as you can because those are really accepted by the community, some research-based, some expert-based, but definitely accepted by the community of the right things to do. And all of those potentially best practices, they really are, they encompass what we're talking about now. So there's the parental education, there's the standardized scoring system, there's a protocol to being used, there's optimizing comfort cares. So all those components are in your potentially best practices that we ask you to do as many as you can at each center. This is a different system that uses those and wraps them up in a different package and presents them in a different way. And the reason we're doing the education is because a lot of centers wanted that information. Even when they joined 2 years ago, the KPQC, they said they were joining because they wanted to do ESC Console. And we said, well, right now, we're not promoting that, but we will get you ready for what that will look like. And that's what we've done. We've taught you over the last 2 years with all our webinars and all of our presentations, all the components of Eat, Sleep, Console. And if you think that it's easier to roll out that package as we're presenting it now, you sure can. And that's what we're trying to give you the material to do. If you say, this is really interesting and we want to roll it out our own way, that's okay too. I think what this does as a kind of accumulation of all that we've taught is it's taking all those potentially best practices that we've supported and putting them together. And you can really do that any way you want. And what we saw from Lisa Wachman's presentation is if they put them together differently to console, and they did fine. So I think that little bit of QI we have and the lot of experience we have is that if you can put together all the best practices and do them well, you're going to have good results. The advantage of Eat, Sleep, Console is it puts it in one place and it makes the education more encompassing, and you're not educating separately on 4 or 5 different bundles. You're putting them all together. Anne asked if we should give the attendance word again in case you forgot it, and I don't know what it is, so it's perseverance. That's what you need is perseverance. I didn't even notice that last time. Is it with a capital P? Yeah, perseverance. That's what you need to get this done, and that's your code word to get CEUs.
Now we need to let them go.
Yeah, it is 12:30, so it's time for us to go into breakouts.
Okay, I can get those started.
And Betsy, correct me if I'm wrong, but we are coming out of breakouts at 12:45. So at 12:45, everybody will come back into the main room to share out what we've talked about in our small groups.
Correct, you're correct.
And I want to draw everybody's attention and to put the link for the potentially better practices on the chat.
So it's asking me to assign people to different rooms, and
You're not already signed in there?
It just has the names of each of the, it has Hayes Medical and all that stuff. I don't know why it wouldn't be
It didn't hold.
here. But there's only 24 people. I should be able to do this pretty quickly if you just tell me like who all goes to Hayes Medical Center.
Hayes, I did not have their list, so it's Michelle Too Good. Michelle, who else is with you?
Michelle's been chatting in. Jessica and Christy.
Okay. Jessica and Christy.
I thought that my participants were in the rooms.
Okay, so in the Zoom call, I have Jessica. I can send there. And then Christy, let me find Christy. Or is Christy actually on the same call or talking through the same phone as Michelle?
I don't know. So can you tell us?
Oh, Christy left. Okay. And then, okay, so just Jessica and Michelle. And then I can, so those are assigned.
Hayes Med also is Hayes.
Sorry, who was that?
There's one that says Hayes Med.
Okay, there we go. Cool. And now Kearney County and Geary County.
So it's Becky Chappell.
Okay, Becky Chappell.
Kayla Schroeder.
Kayla Schroeder. And is that it for?
And Jody Jackson's going in that room too.
Jody? It's just Jody and, okay, cool. And then, so those 3 are assigned. Newman Regional Health.
So that's Heather.
Heather Aylward. Or there's 2 Heathers in the Zoom. There's
Aylward, correct.
Aylward, okay. And then who else for Newman? Oh,
Put both
sorry.
of those. That's, and
Okay.
then,
Neonatal rapid response.
and then you're going in there to bring them back.
Okay.
Neonatal rapid response.
So just Heather and Shannon and Sarah with Heather. Okay, cool. Wesley Medical Center, we have. Oh, oops. Who's from Wesley Medical Center?
All right, I'm going to try this. Shelby, Sierra, Lori,
Got it.
Diane, no, Lyman.
Okay, Danielle Lyman.
Yep. Jessica,
Jessica. I'm not seeing a.
there. Alicia Sanchez,
Okay, Alicia Sanchez.
Heather, Aimee, Carol.
Which Carol? There's two. One with a capital and one with a lowercase c.
Wesley, you're going to have to tell me. Alicia, could you come off of mute and tell us which Carol is your teammate?
Sorry, there's a Carol in there. Let's see.
Carol Hancock, but I don't know which one is which.
When you see
I have no idea which one is which.
You can always, if the Carol's in the chat, you should be able to click on your name in the participants window, and you should be able to rename, and then that would make things a little bit easier.
Anybody else need to go in with Wesley?
Erica Jean.
Okay, Erica Jean, and then.
And Denise and Cheryl, I'm not sure if they were on the list.
Capital C Carol is for Wesley. Okay, cool. And Via Christie.
Amy Henry, can you come off mute and tell us who needs to go with you?
Lindsay.
Okay, Lindsay. Then all we have remaining is Denise and Cheryl, lowercase c Carol, and somebody with the name QUZ6156.
Denise and Cheryl should be with Wesley.
Okay, with Wesley, got it.
And Quinlan, could you please put Anne in with Via Christie?
Via Christie, yes. Okay, I just have the three. So Betsy, where would you like to go? Oh, sorry.
With Hayes.
Sorry, what was that?
Betsy's going with Hayes.
Hayes, okay. Hayes. Okay, no, I just have lowercase c Carol and the QUZ names. Otherwise, I'm ready to break out into rooms.
Let's break out, thanks.
No problem. And I'm going with, you said, which room did you say I was going with?
Oh, Quinlan, you're going with Newman.
Okay, Newman, got it. And open all rooms. You should have gotten invites and you should be able to hop into them.
Welcome back into the main room, everybody. Thanks for coming back. We'll wait for everybody to reassemble. And when everybody's back, we do have one assigned person from each breakout room who is going to report out just for a minute and a half briefly on one of your SMART goals. It looks like everybody's back in nearly. Betsy, do you want to come on mic? And basically, we want to show your next slide because it shows the people who are going to speak. And I can just tell you right now, Kayla, from Gary County. You're going to be the first reporter for about a minute and a half. Maybe share one of your SMART goals, make it specific, measurable, achievable, relevant, and time specific, and let everybody know what you've come up with as a team. Kayla is going to be our first speaker.
Okay. So we need to get our pediatricians on board. So our first goal is to talk with them and get them to complete the whole NAS curriculum on Vaughn, because they have not done that part yet. And we want that completed by June 1st.
You typing to Quinlan that?
I can talk. What?
I know
Oh, you want me to type it?
that the other center we were working with, they are also currently trying to get their providers on board and completing their NAS bundles, but I don't know their date of when they want it completed by.
Betsy, unless you want to chime in, that sounds specific, measurable, achievable, relevant, and time specific to me.
No, it definitely does. Can you, Quinlan, I can't share my screen, sorry.
I will see if I can fix that for you. Oh, it's because it made you no longer a co-host, but I'll fix that.
All right, and while we're waiting for that, Becky Chappell, I'll let you know that you're up next to come on mic and let us know one of your SMART goals, please.
Michelle.
You should be good to screen share now. If I did that correctly.
With Gary County, so we shared the same goal, SMART goal.
Oh, right. I heard that. I apologize. Thank you. Hayes Medical Center, Michelle, could you come on and talk about your SMART?
Hi, this is Jessica and Michelle. We're together now. And ours kind of involves our pediatricians to start with as well, talking to talk with them at their May provider meeting about information that we have learned and share some resources with them. And also, since we're affiliated with University of Kansas Health System now, reach out to them and share information from them as well.
Okay, now, because now we can't hear you. Okay, then let's hear from Newman Regional. Heather?
This is actually Sarah. I think our first goal is to have a luncheon that includes our providers, the OB and the pediatricians, and to just get more information out there to do prenatal education, and then for our pediatricians, just more about the Eat, Sleep, Console concept and how it's a little bit easier than actually using the Finnegan scale and everything.
Super, thank you. And Danielle Wesley.
I don't know that we meet all the SMART categories. We needed a little more time, but a couple of the things that we talked about are we have a cuddler program in our special care nursery, but not one developed for our babies that are rooming in with moms. So looking at working on building up a cuddler program. And then another goal, just strengthening our non-pharmacological practices with providers and nurses and what that looks like. And then developing those cards with NAS and now symptoms on them and putting them all over the units just to kind of raise awareness as we start to transition to Eat, Sleep, Console.
Okay. Terrific. And Amy on Via Christi, share your SMART goal.
So ours is actually to create the multidisciplinary team to discuss our plan creation. So far, we've only kind of educated our nursing staff. So just bringing them and our OBs, our peds, our social workers all to the same table. We really liked the YouTube video that was part of preparation for this. So we felt for those who haven't been involved in the multiple education pieces for them to watch that before coming. Of course, we'll have the tool, we've got the challenges and solution sheet, would also be really beneficial as we are coming up with our overall plan.
All right, Betsy, are you ready to be back on?
I am ready to be back on. So, no, and I actually was in the room with Hayes, and they had, even though they shared one thing, they have a lot of good things that we talked about. So, as we move kind of towards our close, just if anybody has, if you have questions, any closing thoughts, we'd love to hear them at this point in time. Are you watching the, Dr. Jackson's watching the chat right now, because once I bring my screen up, I can't see it. So it's just final thoughts and stuff like that, especially for us, because this was, I think, more difficult for us because we can't just see reactions and stuff like that. But now's the time if you have any questions for us, that would be great. As I do set up the time and date for the sim labs, I will get that out to you. It's my plan hopefully to do 3 sessions that day so that we can get everybody in, and then we can really focus on getting you guys good simulation experience, because I know it's going to be broken up. Usually, hopefully we could, in our last, when we did in-person ones, we could flow right into the sim labs and you guys would have everything fresh. So this is kind of hard.
Something that might help is, oh, I'm muted, hold on.
No, I don't want to be.
Sorry, you can hear me, all right? You guys can hear me? Sorry, one thing that might help is the day or two before the simulations, go through those videos that Betsy sent you. I know going through them before this probably was confusing, as some people said, but now that you have all this information and you reviewed the material, if you can go back through, do you send 3 videos? Mm-hmm. Yeah, so there's 3 videos, and if you just go all through all 3 and score them as you do them, that may help you to be ready for the simulation. Also, maybe looking at the practice cases we just did, or looking back at this presentation at parts if you need to. It seems conceptually a lot easier than it is. And I think that's why a lot of people kind of globbed onto the idea of wanting to do this system. It seems easy. Oh, are these eating, sleep, or consoling? That's so easy. But I think you guys realize it's not that simple now. And the more you can do to prepare, the more comfortable you'll be with the simulations. If you just come along with simulations, they get to be pretty uncomfortable because it's hard to remember everything on the fly.
So, is my screen not up? So, it's just me?
It's just you.
Oh, you're kidding.
Betsy wants your screen up if anybody can help her with that.
Is it still not giving you permission, or is it?
I thought it was up, but I guess.
No, it's not up. It was up. It's gone.
Oh, gosh. Just a second, guys, because you need this part of it.
Betsy, if the only slide you have left is the links, I can put it in the chat.
Okay.
Okay.
So, but what I was going to tell you is the videos that we're talking about are, when I sent you out the pre-work, it's under the OSCE for Gold Star raters and for moms. That's where those videos are. There's 3 of them and they have YouTube links. So if you want to look at those videos, that's where they are. So as far as for the evaluations, and Ann will send those out, they're also on the slides that we sent out. There's one, survey 1 is for your CEUs. So if you signed up for CEUs before our meetings got canceled, we're still going to be able to give you CEUs. And that's why we were really good about giving you the code word. You will have to put that in the survey CEU 1. And then you'll have to, you'll put your name, your license and stuff like that, send that one in. The program evaluation is anonymous. We want you guys to fill that out because that's the key for us to know how to do this again virtually. So that will really help us if you'll fill that out as well. So we need you to do Survey 1 if you need CEUs, Survey 2, Survey 2 if you didn't apply for CEUs. So, and then we will get the rest of the CEUs when we meet back in the sim labs. So, questions for us before we finish up for the day?
And could you say?
This is Anne. I apologize. I had edited the program evaluation so that it could be anonymous, but I'm checking on it now and it looks like it's not anonymous. So Betsy, I think what we have to do is when we get this fixed, we need to send it out to everybody via email.
Okay.
All right. However, so if you are looking for CEUs, please do use this link that I gave you that's called the CEU survey. That's the one that you use to affirm your attendance today, and that one's good to go.
And you stay on the phone for a minute when everyone gets off so we can talk
She
about
has
some
to
other
go to
things.
another meeting.
Oh, never mind, Ann. Betsy says you have to go. We'll meet another time.
And then there's a couple, maybe Ann has them, but if there's a couple of you I don't have emails for, if you will email me your addresses so that I can get to the program evaluation, that would be great. I think, Michelle, I'm missing Hayes emails from today. I have everybody from Wesley. So. And I have the other centers, so. Okay, if there are no other questions, then I thank you guys for coming. I thank you guys for your patience with my lack of technical skills for today. Do you have any other?
No, thank you. I think it went well, all being said, and we look forward to seeing your evaluations.
Okay.
And let us know if you need anything.
Yes, absolutely. And I will let you know as soon as I know the dates for the sim labs. Thank you.